So good morning, everyone. It is a huge pleasure to have you all there who actually managed to reach Vilnius in this morning. I know a lot of people are still coming and some of them fighting with the airlines, but hopefully they will manage to reach Vilnius. So we started once again Vilnius Vascular Symposium. This year we have upgraded to 2 stages, this and the one next to it. And yeah, we will see, is it worth to go through 2 stages? And definitely we would like to thank our sponsors. And it's both companies, medical industry companies, and public institutions. So just to mention Go Vilnius, which is actually also supporting us. So we are happy to have them. We are grateful with them. And yeah, Arturas, would you like to step in?
Yes, hello everybody. I would like to welcome you for coming here to Vilnius. And as you can see, those who have been in last Vilnius Vascular Symposium, we have a growing amount of people. This year we have more than 300 people here coming. Thank you so much for coming to Vilnius. And as you know, yesterday I told some people that the idea of symposium is from Greek language. It's a party celebration meeting of the friends. So let's start the symposium and welcome to Vilnius Vascular Symposium.
So let me invite the moderators of the first session. So Giovanni Federico could not come, he's in Frankfurt still. And I would ask Giovanni Torzello to come and join our very good friend Aina Kratowska. So, and those people who are going to telegraph session, dialysis session, these doors are working and the other doors are working. So please split.
Hello? Quite loud. Dear colleagues, thank you very much for coming, and to our very best friends in Lithuania, to Arturas and Tomas, thank you very much for welcoming once again us, and thank you for not being annoyed seeing us already for, I don't know, 1,000 times. And I'm happy to open the session of radiology, vascular radiology, because I think that these 2 entities, vascular surgery and radiology, are very, very close, not only in, let's say, daily practice, in our daily jobs, but also we know that a lot of people from our community are friends and we are doing the friendship between radiology and vascular surgery, and I think that we will be able to continue that forever. And that's why, as the first speaker, I would like to announce Dr. Gagarina. She's a radiologist from a children's hospital, and we'll have a really interesting topic of her speech, because now, well, mainly in our daily practice we get only adult people to treat, but a lot of vascular pathologies start in childhood, even very early childhood, and that's why Dr. Gagarina will tell us what we can expect in our adult population, which is coming from pediatric population. Thank you.
Good morning, everyone. Nice to see you. And because it's first presentation, I want to start from the beginning, from the moment of birth, because my patients are from 1 day old to 18 years old. So, and my presentation summary has no go only path and aortic arch variants and anomalies that I see very regular. So let's start. I found a lot of schematic of aortic arch, but there is a lot, and it's just 15% of everything that it's possible to develop in a baby. So, but we will speak about just a few of them, about a half. So I will start with the most common anomaly is aberrant subclavia, that it can be from right-sided and left-sided aorta. So this is my beautiful patient, 6 days old, with classical right-sided aorta and aberrant subclavia with a little compression to trachea. And before of this type of surgery to reconstruct this aortic arch, we ask for pulmonologist consultation for any type of fusar obstructions. So, second one, as well, very common, is bovine arch. So when few of carotid brachiocephalic blood vessels have one beginning. In this example is brachiocephalic trunk and second carotid artery. So different variations, because all of these blood vessels can be with common origin, and how you see 4 variations of bovine arch. So next to it, very rare but as well possible, is epi-aortic single trunk. It can be quite dangerous for patients because all brachiocephalic blood vessels starts just with one huge branch. Rare case, I found in literature only one example, and you see this example on the right side of my presentation. So angiography, MRI, accidental finding. And there, it's experimental, invasive, diagnostic for ovine arch. It's not a patient, it's animal, it's case from our colleagues veterinarians. But this can be in humans as well, like a nature joke. Sometimes it's possible to see common start from carotid arteries, and it's called truncus bicaroticus. In this example, you see that both have one origin, and what interesting, both subclavine as well have one osteum, and because we have bull arch, sheep arch, and this pathology called avian arch. It's common in birds, but it's about 6% in people have this as well. There is example what do in pediatric our vascular surgeons. So most common abnormality of aortic arch is aortic arch distal third reducing in diameter, so every type of correctation, and we have 2 major surgeries to reduce it, to renew the aorta like it must be. The first option, just to take a little bit of subclavian artery and have a graft. So, but we will connect all the subclavian artery to the carotis. But sometimes we have without this connection to carotid, and there is just blind end of subclavia. It sometimes can be absolutely asymptomatic, but sometimes patient says that they have reduced temperature of the hand, reduced sensitivity. So it's better to precise what happened, especially if patient doesn't remember what was in his childhood, any type of surgeries. And why it's necessary to describe in our CTAs exams, because if we go through this arm, we will see only subclavian invertebra without connection to aorta if we something need to do there. And there is example with this blind end and a little bit of surgical material where it closed. Not so common, but can be a little bit dangerous, is every type of aortic interruption. But as I said before, and the aim of presentation, we will have plan B. So there is beautiful example how our blood vessels have second way. So intercostal, internal mammary, and superior epigastrical artery to connect everything between, especially chest cavity and abdominal cavity. And second way can be through intercostal, intermammary, and subclavian arteries to support blood supply to everywhere. So sometimes it can be asymptomatic and can be found only in patients after 18 years old as incidental finding. Not so common, but can be mentioned is Gothic aortic arch because during interventional procedures, it can be a little bit tricky to find a way to the ascending aorta. So you see how sharp is this angle. It can be tricky and take a little bit more time. And common, about 11% in different populations can have double arch. Two ways. One goes to the ascendens, one goes to the brachycephalic. And most interesting that can be diagnosed without imaging is cervical aortic arch. And as you see, it's visible without any type of exams. It can be dangerous, especially in patients, for example, car accidents, but we can see it, we can touch it, we can precise it with CT and angiography, and sometimes, definitely, it can be without symptoms, but patient just has this lump on the neck, but doesn't worry about it. And because of this asymmetry of brachycephalic blood vessels, it can be tricky for stenting, overlapping, and taking some grafts. And I want to end that knowledge because really such only when it assimilated in the mind of the learner and shows in this character. So in Nazani body, from Bushido book, Soul of Japan, so Samurai Bible, and everything is possible, especially from the nature. Blood always find a way. Sometimes it's a little bit tricky and long. Thank you.
Thank you to Jekaterina. Maybe somebody from the audience has questions, or Professor Tercelo, maybe you?
No, I don't have question. I'm very, very glad to have such a beautiful lecture as you have done. Congratulations. Very, very impressive cases also. I don't have specific questions to this talk. Otherwise, at the end of the session, we have also the opportunity to make a discussion.
Thank you.
If you agree, I would like to call the next speaker. This is Dr. Schwarz from Augsburg, Germany. He will speak about photon counting CT in vascular imaging studies and real life. And by the way, I would like to introduce myself. My name is Giovanni Torsello, but I'm not the right one. So I'm a substitute for my son. He's one of the people stranded in Frankfurt without the possibility to come here in the morning. Sorry for this. Dr. Schwarz, please.
Yeah. Thank you very much for the introduction. Thank you for inviting me to give this presentation. I'm very honored to be back to the Vilnius Vascular Symposium. Right now let me see. No. I was in Augsburg for 7 years, and I recently changed to become the head of radiology in Deggendorf. But like in Augsburg, I was lucky enough to be among the first ones to have access to a photon counting detector CT. There is one on the market right now that's sold by a German supplier of CT machines, and it comes with a double tube, double detector array, and here I included some technical details. It has a very broad detector, and it has 2 of them. And the interesting thing about the photon counting detector is that it's a completely new technology, how to detect X-rays and how to translate X-rays into an electrical signal. And this is for the first time for like 30 or 40 years, a completely new technology. That's the old one. It's a 2-step process in the old one. The old technology uses certain ceramics that have that when they are hit by X-rays emit photons in the visible spectrum, so light more or less, and then the light is detected on the other side of the ceramics, and that works really well, as you all know. Like this normal CT technology is extremely far advanced, and we can make now like really nice pictures with very, very low X-ray dose. But also, it's very hard to advance this further because, like, there have been like hours and hours and years of manpower has been put into this already, and it has reached a point where the further development will be extremely difficult. And so the new technology looks different. It's a single conversion process. So it uses a completely different technology to convert X-rays into electricity, and it uses a semiconductor layer of cadmium telluride that is put into an electric field, and when that is hit by X-ray photons, there is a certain change in the distribution of electrons, and this change can be measured on the other side. So there's no translation into light, but it can. So the X-ray photon directly induces an electric signal on the other side. That can be measured. It is extremely difficult to do that. So technically, this has become feasible only like 3 years ago or so. It's extremely difficult to do it, but it has a lot of advantages. It also is very difficult to do, and it also has a potential for artifacts which you need to be very careful about. But the big advantage is, there are 2 advantages. The first one is it has a much higher spatial resolution, and the second advantage is that not only can you see that there is a photon, like from the X-rays, but you can also exactly measure its energy. And yeah, that has big advantages that I will now show you for vascular imaging. And as I said, it's spatial resolution, and you can do a lot with this spectral information. So you can enhance your iodine in the data set, and you can also do material differentiation. This means you can, for example, tell apart calcium from iodine. So when you have something that's bright in CT, you can now say, is this brightness due to calcium or is it due to iodine? And you can do it with any data sets. So you don't have to decide that you want to have this information in advance. So I'll show you something. Just Aina said I'm not supposed to show you too many mouse pictures, but it's my presentation, and this one you have to see. Because we had the first scanner, we wanted to scan something really tiny, like really, really tiny structures. And so what I did, I went to a store that sells pet food, and they had frozen mice for people who have snakes. And so I bought 2 frozen mice, and we scanned them. And we compared them between a normal CT and a photon counting detector CT, and we measured various parameters. And what you see is that the noise is generally lower, and signal-to-noise ratio is higher, and the edge sharpness is higher. But here the images, I think, are more convincing. So here you see the cervical spine of the mouse in a coronal reformation on a normal CT with decreasing dose. And you do see that even with very high doses, the resolution is not really very high. You can see that there are some transverse processes, but it's kind of shady. This is the new machine with a kernel that is comparable to the other one, And you do see here that the resolution is much better. You see much more of the transverse processes and even at lower doses. But you can increase the kernel here and come to this. And then you see that here, when you have higher doses and this very sharp kernel, you do see much, much more of the cervical spine. So you do see the end plates, you do see the discs even. And I'll show you that again. That is a human cervical spine. And when you look at it, this is 7 millimeters. That's the dense. And inside this small structure, the entire mouse cervical spine fits in, right? And so when you increase it, so this is the view from the photon counting detector with the high dose, and you see that you can differentiate individual end plates. You can see the transverse processes, and this shows you the whole data set again from the photon counting detector from the mouse, and also, and afterwards the comparison from the conventional CT. This is the normal CT high dose. You see the spatial resolution is much higher. So this, this helps you a lot when you do stent imaging, for example. You can see it's much better to look inside stents. You have much less blooming of calcium, for example, as well. That's also extremely helpful. What you can also do is this. You can see when you acquired a data set with contrast material, such as this one, for example, what you can do is you can say afterwards, I want to enhance the iodine. So I want to see more of the iodine. And you don't have to do another scanner. So, and I'll show you that. You see now it gradually enhances the iodine. So you can do that with any scan after you have acquired it and when you do the readout, right? So this gives you a lot of possibilities to improve the contrast, for example, or also if you know that you can rely on this effect, you can just also give less contrast to scan, right? So this again puts those two things next to each other. This is the normal reconstruction and shows you the lung vessels, but you can do then, it's just like a slider. You slide it to one side and say increase iodine, and then you see much more of the vascular structures, right? Another example here is whole aorta. Same thing. Also, so this is like the whole data set has this spectral information, and this you can use that to exactly differentiate what is calcium, what is iodine, and you can say, please increase the iodine in this image, make it more pronounced, and this is what I do here. And one thing is also important because the computer can tell what is calcium and what is iodine. You can also tell him, now take all the iodine out of the image, okay? And I'll show you that soon. So look at the calcifications here, and let's take the iodine out. So and this is like really real time. So this, you can do that while you do the readout. You see now I took the iodine out and only the calcium remains, right? So this is something that has not been possible up to now to that extent that you can do it in very, very long scan ranges. Another example here, just to show you that this can help you, for example, if parts of your contrast of your data set don't have a very nice contrast, you can use it to improve the image quality there. But it's basically the same thing. You see now the aortic arch in the thorax looks much better. You see the coronary artery suddenly. So this can help you if you know that you can rely on this effect, and you can, then you can considerably decrease the amount of contrast that you give to a patient, right? We also published that you can use it to look at endoleaks. For endoleak detection after aortic stents, you typically need an unenhanced scan, and we published that you can use this virtual non-enhanced scan from the CTA to substitute for the real unenhanced scan. So this could save you time and especially radiation. And I'll show you a PE study like pulmonary embolism, just here. Coronary reformation, to give you an idea. That's a pretty severe pulmonary embolism here. So you just saw that there are pulmonary emboli all over the place, like left lower lobe and many segments on the right. And what you can do with this technique is visualize the iodine. And this, you see it here. You see that there are segmental perfusion defects in the lung. This is also something that has been quite difficult up to now. But with this technology, it's possible. I'll show you two more things, and then I'll let you go. There's, you know, when you do a coronary CTA, you typically perform an unenhanced scan first to do calcium quantification, and then you do the CTA, right? If you can remove the iodine from your data set, maybe you don't need the unenhanced scan, right? And that's what we showed, that this is possible. Here you see it again. This is the true unenhanced scan, and these are the two virtual unenhanced scans. And those are derived from the CTA. And then we quantified calcium, and we, you see that the calcifications are very, very similar. And so you actually can derive the calcium score from the CTA using this technique if you wanted to do it. This is my last example, just to show you the, another effect that you can do with this technology. Look at this pelvic arteries here. And so that's a MIP image showing you also calcifications, and what is even more interesting than to take the iodine out and look at the calcium is to take the calcium out and look at the iodine, right? That's, especially for vascular surgeons, even more interesting, because you want to know if you disregard the calcifications, what's the lumen that is left in the vessel, right? And you see it here. So you can do that also very easily because it's just like the complementary data set to the other one, right? And you do see that that you can just look at the lumen this way. This would be the complementary calcifications. So I want to summarize, like photon counting detector CT is based on a new detector design that is really substantially different from what is built into normal scanners nowadays. It has higher spatial resolution. I showed you the example from the small patients. It's good for stent imaging. It has less blooming artifacts, and this can also, of course, help you then to quantify stenosis, especially in coronary arteries. And there is spectral information that you always have. You always have it available. You can't even scan without having this information. And with that, you can, for example, reduce the amount of contrast material that you give, or you can enhance the vessel contrast in your data set. And with that, I want to thank you for your attention. And if you have any questions, just ask, or I'll be around later as well.
So, dear colleagues, does anybody has questions? If not, may I ask you, Florian,
Sure.
something? So, as you were one of the first persons in Europe standing nearby the advancement of photon counting technology, so what can you say how this technology has developed in recent years, and is it being now implemented into more and more into daily practice? And the second question, do you see also the possibility to change the guidelines regarding GFR threshold that we allow to our patients to undergo CT angio?
So photon counting has been the idea of doing that, using this effect that you have from a semiconductor when it is hit by X-rays, has been around for maybe 10 or 15 years, and all the vendors were thinking about going into this. And the German vendor was the first one who was the first mover in that. They did a very strategic acquisition of a Japanese company, which was crucial to build those crystals. It's really difficult to build these crystals. And they were the first one to do it, and their strategy of introducing it was to put it into the flagship scanner at the very, very high end of the spectrum of CT machines that they have. And those scanners typically are only in the reach for university hospitals, right? So that was their strategy. They just pushed it out to most of the German universities where they now stand. There is one or two private practices that even bought one as well, but I think more for marketing reasons, honestly. And I mean, initially it was a little bit slower than the normal CT, like you had to wait longer for reconstructions and things like that. But now this has all been evened out. Now you don't really see a difference. You have this additional information. And when you look at the literature, for example, it started to take off relatively slow, but now when I look at radiology or radiographics, for example, like I just yesterday saw that there is a special issue in radiographics about the head and neck imaging, and there are two publications about the advantages of photon counting detector CT. So I think it will distribute, it will also dribble down into the more affordable segments. And I hear that they are planning to release a single source scanner in a more affordable price range, I think sometime next year or so. And, but we will, yeah, and I think then we will see what happens. I think all the other vendors are also almost there. They also want to go into this technology, but so probably it will be quite an interesting business study case in 10 years from now in Harvard Business School or so, if the first move thing was an advantage or a disadvantage, right? Sometimes there is a first mover disadvantage because sometimes you run into problems that you haven't anticipated, but all the other vendors then know that this problem exists because the first one has run into it. Regarding your second question, the GFR thing, actually I think that this is shifting anyways, you know. I think photon counting will not really be crucial for that point. I think what we see is that most of us overestimated the detrimental effect of contrast material on the renal function when you give it intravenously. And I think what you see is that first of all, you can also, with normal CT, give much less contrast if you do low kV imaging. So if you scan at 80 or 90 kV, you can give much less contrast than when you scan at 120 kV because iodine is brighter at lower kVs. And yeah, and I think, but I think it's a general trend towards scanning patients with worse GFR. But this will probably not be the crucial point in that. Yeah. Okay, thanks. So I think the micro is out. I think it doesn't work.
Yes, now.
Yep.
I have an additional question about the CT angel because it's essential for the planning of so many procedures.
Yes.
And the drawbacks of CT is calcium, if you want to appreciate the lumen behind the calcium. The second one is radiation exposure. The third is contrast medium. And the fourth, concerning now the technology you have presented, are the costs.
Yes.
Would you please briefly say something about the calcium, especially in small vessel disease?
Yes.
Below the knee,
Yes.
coronary, you have shown some pictures.
Yes.
Do you think that with this photon-based technology, we are able to see more behind the calcium? And what about the reduction of radiation, contrast medium,
Yes.
and costs?
Costs right now are definitely higher because the technology is simply more expensive to build, and they can, of course, add a big premium because they are the only one on the market. So it's affordable right now in Germany only for university hospitals who have it financed by some from the German research foundation thing. But it won't stay there for sure. This is always how new technology is introduced, has always been like that, and it will trickle down into more affordable segments. Regarding calcifications, it has already now been shown that in the coronary arteries, it does help you a lot because, you know, the thing is that when in patients with a lot of coronary calcium, there's like stenoses tend to be overcalled. So we tend to send patients to cath after CTA, of coronary CTA, when they have a lot of calcifications, and we and very often then the cath comes back more or less normal or just with like 30 or 40% stenosis, right? And it has been shown that especially in those patients, this reduction in calcium blooming is beneficial, and it allows you to more correctly triage those patients with severe calcifications into those that really need a cath and those that don't. That has been published already, so there is good evidence for that. But the other, like your question was excellent with the lower legs, because I also think that that is one of the weak points of CT often, that especially in patients with diabetes or so, you have such incredibly calcified arteries. And this is where this technology will probably get. I haven't seen anything on it yet. I think it's more difficult than it was anticipated, because the ratio between the calcium in the walls and the lumen is pretty unfavorable. But I think it will get there, yes. Regarding dose, you can easily scan at the same dose. It's probably 30% lower or so, generally. But this is partially due to the new technology and partially due to other things also on the tube side. But the dose is more or less the same or lower generally, yes. Yeah, thank you.
Yeah. Thank you, Florian. So the next speaker is, do we have Dr. Kobak? Yes. No? About abdominal and pelvic vein thrombosis? Ah, yeah. Hello. Hello. Nice to meet you. So the stage is yours, and the topic is about the abdominal and pelvic vein thrombosis and post-thrombotic obstructive lesions and diagnosis by magnetic resonance venography. Yeah. Really interesting topic. Thank you.
Thank you. Good morning. Dear ladies and gentlemen, my name is Joanna Kobak and I represent Chair and Department of Vascular Surgery and Angiology, Medical University of Lublin. Today, based on our preliminary clinical study, I would like to draw attention and I would like to answer the question of whether minimally invasive examination could be even less invasive. And thereby, I would like to draw attention to an entirely non-invasive and nowadays not expensive imaging method that is non-contrast enhanced magnetic resonance venography, and to demonstrate its feasibility and accuracy in diagnostics of abdominal and pelvic vein thrombosis and post-thrombotic obstructive lesions. Currently, the most commonly used imaging method for diagnostics of abdominal and pelvic vein thrombosis and post-thrombotic obstructive lesions remains computed tomography venography. As a gold standard in such cases is considered contrast venography. However, both these methods are associated with exposure to ionizing radiation and necessity of intravenous iodinated contrast media administration that may be potentially harmful for patients and also for surgical team in case of ionizing radiation. Along with advancement of magnetic resonance systems and development of new sequences, magnetic resonance examination without contrast media administration arises as an optimal imaging method when thrombotic lesions of the proximal veins are suspected. The aim of our study is to determine the sensitivity and specificity of non-contrast enhanced magnetic resonance venography in assessing of acute thrombosis and post-thrombotic obstructive lesions of the abdominal and pelvic veins. Our retrospective analysis of prospectively planned study encompassed 60 NC MRV studies that had been performed in 57 consecutive patients from December 2020 to February 2023. 8 patients were excluded due to inability to participate in follow-up that resulted in exclusion of 9 studies from analysis. 3 patients were diagnosed at first with acute thrombosis and further with post-thrombotic obstructive lesions, hence the disproportion in the number of studies and patients. Non-contrast enhanced magnetic resonance venography examinations were conducted using 1.5 Tesla unit. There were performed the following sequences, including inter alia 3-dimensional infro-inversion recovery, 3-dimensional cube black blood, or Fiesta sequences. The obtained images were subsequently evaluated by 2 experienced radiologists. As a reference methods for evaluation of both acute thrombosis and post-thrombotic obstructive lesions were considered computed tomography venography and contrast venography. When it was impossible to pertain to the reference method, clinical follow-up lasting at least 3 months was used. That consisted of meticulous analysis of medical records and telephone contact with included patients. For acute thrombosis, we used also Wells criteria assessment and D-dimer level measurement. And for post-thrombotic obstructive lesions, we used Villalta post-thrombotic syndrome scale assessment. There were 13 cases with suspected acute thrombosis and 37 cases with suspected post-thrombotic lesions of the abdominal and pelvic veins. Only in 1 case concerning post-thrombotic obstructive lesions exclusion, NC-MRV result was inconclusive, and confirmatory computed tomography venography or contrast venography were not available, while patient presented symptoms distinctive for post-thrombotic symptom. Hence, this case was qualified as a false negative. A non-contrast enhanced magnetic resonance venography revealed 100% sensitivity and 100% specificity for detection acute thrombosis of the abdominal and pelvic veins, and further 97% sensitivity and 100% specificity for abdominal and pelvic veins post-thrombotic obstructive lesions detection. Here we can see NC-MRV images depicted acute thrombosis with confirmatory venography. And here we present some NC-MRV images revealing post-thrombotic obstructive lesions. Moving on to the conclusions, non-contrast enhanced magnetic resonance venography appears as a highly accurate imaging method for detection of acute thrombosis and post-thrombotic obstructive lesions of the abdominal and pelvic veins. Retrospective analysis may be hard owing to daily clinical dilemmas associated with diagnostic and therapeutic approach individually tailored to each patient. And conducting a clear and unified prospective research is extremely difficult owing to ethical dilemmas caused by limitations of computed tomography venography and contrast venography being reference methods. We are aware limitations of our study. We followed the natural course of events in our center. In almost half of cases, MRV studies was the only performed imaging examination owing to patient's condition, as renal insufficiency, reproductive age of female patients, allergy to iodinated contrast media, or simply a lack of patient's consent to phlebography that remains invasive procedure. Thank you very much for your attention. If you have any questions, I will try to answer them.
Any question from the audience? How many people in the audience use such a technology at home? You are the only one.
We are the only one center in Poland that performed this type of examination, and probably Warsaw now started this examination. But Lublin was first, and we performed these examinations.
Yes. Between acute and real chronic, there is a gray zone.
Yeah.
With thrombosis, which can be 3 or 4 or 5 weeks. Do you think that you can, with this method, can say this is a good case for thrombolysis or for mechanical thrombolysis with this method?
Yeah,
Would you differentiate the therapy?
We try conduct a study in this area, and we see that it is possible and is very useful in daily clinical practice.
Thank you so much.
Thank
If
you very
we
much.
don't have any question, it's my pleasure now to introduce my co-moderator, Dr. Kratowska, who will speak a kaleidoscope of vascular radiology cases. That will be an interactive case quiz.
So, dear audience, the topic of my talk today was supposed to be like kaleidoscope of different cases, but I've selected one in which I had a really kaleidoscope of events. And this is the case I would like to present to you as both radiologist and also interventional radiologist, and to show how it went out. So, we've got a call on Friday evening from our very well-known and highly experienced surgeon, liver surgeon, who did partial gastrectomy 1 month ago on a patient. He, vice versa, received a call about this patient from a regional hospital because the patient was admitted there with a sudden onset of sweating, loss of consciousness, and he had hemoglobin decrease, like 9 grams per deciliter, and also a slight hypotension. But he was more or less hemodynamically stable without vasopressus. So if we run a CT angio here, so that's arterial phase, take a look really carefully because I will ask, what do you see? And I will maybe go back once again from up above. So, is there a clue for a diagnosis to somebody? Don't be scared. So, the options. Hemorrhagic pancreatic pseudocyst. If somebody thinks, raise the hand. Okay, no. True aneurysm of hepatic artery. Nobody. Truncus bifurcational pseudoaneurysm. Yes, professor. Other. Okay. But the correct answer was that Professor Jakimowicz said. So it's truncus bifurcational pseudoaneurysm, which most probably occurred due to lymphodissection in that area, which was done. And that's why also our surgeons called for help, because they really didn't want to re-intervene in that area. But that patient has been discharged almost 1 month, 20 days ago from our hospital. And if we take a look, and that's the story about the ionizing radiation amounts that we use in our daily practices to diagnose the patients. And if we take a look very, very carefully on this CT scan, which was done only in a Porto venous face, we see that there is something additional in the hilar area that shouldn't be there. Yeah, so although that was a portovenous face, a really careful glimpse at this area would most probably save this patient from coming back to the hospital. So this entity was missed. Yeah. So how do we treat such a tricky lesion? It's located on the bifurcation of truncus celiacus. So what do we do? As this is a Friday, maybe a good idea is to run away. I would like to do that. Open surgery, because the lesion is on bifurcation. Who would do that? Yes? And the vascular approach, who would go for that? So more people are about to endovascular approach. In that case, how would you do that? Would you do the embolization of this aneurysmal sac with coils? Nobody? Yes, there is one answer. Would you only graft from truncus celiacus to hepatic artery? Who votes for that? Yes, Professor. Would you do also proximal embolization of splenic artery with coils and graft to hepatic artery? Yes. Or just do a diagnostic DSA, say that you can't do anything and still try to run away? Also a good option. But we went for the double technique because, of course, in these areas where pseudoaneurysm is located directly on the bifurcation, if you do only grafting to one vessel, most probably you may have also retrograde flow from the other one, thus also still continuing filling the pseudoaneurysmal sac. So that was my idea as well. And that's why initially we did also embolization of splenic artery to avoid this entity. But the problem was it was a Friday evening. You never expect these cases. And there was not so many grafts in appropriate sites for this kind of artery. We had on shelf 6 by 22, 6 by 37, and 8 by 57 graft. And estimated size of the hepatic artery according to CT angio was like something like 6 millimeters. So initially, what we did, after the coiling the splenic artery, I will run this DSA image once again. Here you see the neck of pseudoaneurysm. Well, seems pretty easy. Why not? That's why we placed the stent graft in appropriate place, but it was not moving forward, and we thought that we should hit a bit more distal and do the proximal flaring of the graft, but it was not possible. And the idea was to advance it a bit deeper over distal access catheter. Well, with the good intentions, there is a road to hell. We removed the only 6 by 37, which would be the ideal option for this case, through the sheet. But the sheet had its 8 French balking, and it had a really stiff rubber valve. And although I usually in these stents cut the 6 French sheet and use that as an introducer device because these grafts don't have it, in this case we pulled it too quickly and the only graft stayed in sheet, in the valve. So we had to rechange and start everything from beginning. But anyway, we managed to do that. We put it the only 6 millimeter graft left on shelf. Looking more or less good, but still after the placement, primary placement of 6 by 22, still we see some contrasting of pseudoaneurysmal sac, although the position seems more or less appropriate. So to get maybe better result, we did the flaring of the proximal portion with the larger diameter balloon and hoped that it will help. And it looked really decent. That's why Friday evening was finished at this point. But we received a call on Monday. And the patient had a complaint about the chest pain. And he had like an episode of syncope, but he was still hemodynamically stable without vasopressors and lying in his ward. We redid the CT angio, and this is what we see. As you see, the pseudoaneurysmal sac has increased in size. The stent stays there, it's all fine. The embolized splenic artery is there, but the pseudoaneurysmal sac is growing. So not a good job. Well, maybe this is the time to run away, but it's Monday, no way. You have to redo. And what we did, again, if we do the DSA, now actually we do more clearly see that even though the initial position of the stent seemed right, it had to be longer so that 6x37 lost in the sheet would be more perfect. And what we did, again, on the distal access catheter, which was 6 French neuron max, 90 centimeters, delivered to the bifurcation of hepatic artery, and through that one, 7x57 stent graft placed once through the previous stent to ensure that the whole segment is covered. So we did also additionally the proximal flaring at this area to adapt to the vessel wall. And this is the final shot you see. We don't see anymore the contrasting of the pseudoaneurysm. The patient has been discharged yesterday. The also issue was to preserve the gastroduodenal artery in case if this kind of a construction gets occluded. Because I don't know how in your daily practice, quite often we see, even though we try to salvage these patients by placing the stent grafts, there is a chance that grafts occlude, and this is hepatic artery, and the risks are pretty high. So to finish up my talk, there are some take-home messages from this case. So definitely bifurcational pseudoaneurysms are not so easy pathology to treat. Anyway, most probably you will have to sacrifice one of those bifurcating vessels and you have to choose which one is more important. The distal delivery catheter drawn just very much distally to the pathology to ensure that the stiff graft passes through the stenosis very well without being dislodged from the mounted balloon is a good idea. And in this case, the 8 French sheet in the ostium of truncus and 6 French neuron max as a distal access catheter worked really well. Another correction of our mistake is a full stock of small grafts, because usually we have a lot of big grafts, but small grafts are very important as well, especially on Friday evenings. And post-procedural anti-aggregation is also a discussion point, because you have a patient with a pseudoaneurysm that you want to get occluded, but after placement of such a stent graft, of course, the patient has to undergo at least dual anti-aggregation. Yeah? And in patients with suspected bleeding, always arterial and parenchymatous contrast CT phase has to be done. And the other trick is just don't pick up the phone after working time.
That was a really demanding case. Thank you so much for sharing this. Any question or other proposals? One question perhaps about the graft you used. I couldn't get which type of cover stent.
Yeah, initially we used avascular graft, which is pretty flexible and good for tortoise anatomy. but that was the only one we lost. And afterwards we used Bentley.
Bentley, okay. Because the porosity of cover
Yes.
stands can be different. Any question, please?
Yes, Professor. Yeah.
But if you have a self-expandable stent available, would you use it or would you still stick with balloon expandable?
If there would be a self-expandable cover, then yes. But unfortunately, I even don't know on the market. I don't know. There are such sizes like 6 millimeters. The only. Yeah, but it's not available neither in Baltics. I think in Poland it is available, right? Yeah. But in Baltic states, Viabon is not available. Any other questions?
Perhaps one quick question
Yes.
about coiling of the additional coiling, I mean, of the pseudo-aneurysm. Do you think that could help?
If there would be a smaller size of it, most probably I would add additional equals. But as the size was so big, it was initially 5 centimeters, and afterwards it was like 5 by 10. No chance to fill it.
Okay.
If I can comment, it would help coiling because on Monday you wouldn't see anything there on CT.
Okay, thank you.
I don't like coiling of pseudoaneurysm. I think it's nothing good to be done if the aneurysm is so big as this one.
Okay, thank you. Any further question? No, that's not the case. So I would like to invite now
Thank you.
Dr. Paraskevas. Thank you so much. He's the author of the best Delphi consensus paper done. Thank you. But today you speak about the carotid plaque vulnerability. Thank you.
Good morning, everyone. I would like to thank the organizing committee and Arturas Maskevicius for kindly inviting me to Vilnius. I've never been to Vilnius before, and it feels really nice being here with you. So I will talk about carotid plaque vulnerability. Okay. So in the last few years, there has been a change in the guidelines and the recommendations, and nowadays, when we're talking about asymptomatic carotid stenosis, it's becoming clear that the degree of stenosis is not the most important factor, probably, because we see many patients presenting with TIAs and strokes with moderate stenosis. So it has become apparent that asymptomatic patients are not all the same. There are different, they have different stroke risk. And we have this recommendation saying that for asymptomatic patients with 60 to 99% stenosis, in the presence of one or more imaging or clinical characteristics that may be associated with an increased risk of late stroke, a carotid endarterectomy or stenting should be considered in order to reduce the stroke risk, in the future stroke risk. So we have a list of those imaging criteria and clinical characteristics, and we see that a lot of them have to do with the plaque. So we see here interplaque hemorrhage on MRI confers 300% increased stroke risk in the future. So it's one of these characteristics that call for prophylactic carotid endarterectomy at least to be considered. And also we have plaque lucency on duplex ultrasound, which is one of these high-risk features for future stroke. And of course, a combination of criteria, which also confers increased future stroke risk. So let's see first. The first is intraplaque hemorrhage. It's one of the, it's the strongest imaging parameter associated with the occurrence of future stroke. So essentially what we have the, you can see here it can be diagnosed with CT, MRI or ultrasound. And in a meta-analysis of 9 studies, detection of intraplaque hemorrhage and MRI was associated with an increased risk, almost 5-fold increased risk of future stroke. Now in order to understand that, but the five times higher stroke risk is, imagine your salary times 5, and then you get an idea of what we're talking about. We also have a lipid-rich necrotic core. So as carotid plaque becomes, chronic, there are certain characteristics that appear, and one of these is the core becomes necrotic, and you have lipid-rich and a lot of lipids, and this is how it appears, again on CT, MRI, and ultrasound. And this is responsible for destabilizing the plaque and leading to symptoms in the future. We also have plaque inflammation and intraplaque neovascularization. These are also detected by MRI, I'm afraid, so no ultrasound. And this is one characteristic that, of a complex and vulnerable carotid plaque, and it's associated with increased future stroke risk. Now, the carotid plaque thickness is another criterion, and this can also be detected by ultrasound, CT, and MRI. And we can see some images there. Now, this is also one of the criteria for considering an asymptomatic patient for prophylactic carotid endarterectomy or stenting. And we also have a surface plaque morphology. So the carotid plaque, it can be smooth, irregular, or ulcerated. It's supposed to be that, well, there are studies showing that statins stabilize plaque morphology and make them smoother. But it's also a marker of plaque rupture and increases the vulnerability of the plaque. And finally, we have the carotid plaque volume, which in the last few years has appeared as a marker of carotid plaque vulnerability and a predictor of future stroke. And we can see here, the increased carotid plaque volume is one of these characteristics that call for prophylactic carotid endarterectomy stenting. Now, there's this paper published earlier this year by Luca Saba, a good friend of mine. This is an attempt, we're like, I think it was something like 35, 40 authors, and we're trying to make a categorization of the plaque type. And we can see here that, the normal wall, as the plaque progresses, obviously it becomes more unstable. And there are a couple of imaging criteria, as you can see here, that increase the risk of stroke. So, in conclusion, plaque vulnerability is a key issue. It's actually more important than stenosis itself. We see patients with unstable plaques presenting with neurologic symptoms, even though the degree of carotid stenosis is not so great. And so we now know that it's associated with increased risk of future stroke. I missed that word there, sorry. And it's a key criterion for the decision-making in the management of asymptomatic carotid patients. And this is a paper we published. I think it's full text. It's freely available from a Journal of Stroke, where we discuss these issues and why the management of patients with asymptomatic carotid stenosis needs to be individualized, because not all patients are the same. And those with unstable and vulnerable plaques definitely should be considered for a prophylactic carotid intervention in order to avoid a future stroke. Well, thank you all for your attention. Any questions?
Thank you, Cosmas, for your presentation. And my question is, what can you suggest which examination is the best? CT, MRI, duplex, or all together, 2 in 1?
Right. So, well, the thing is, the first thing that you should keep in mind is availability. So not all hospitals have MRI, for example. Also, there's the issue of cost. An MRI is much more expensive than any other diagnostic imaging. So initially, we should start with the ultrasound. If you have a good ultrasound, you can detect many features of the high-risk unstable carotid plaque. Well, obviously, ideally, these patients should have an MRI, but I don't think it's possible, with the way that hospitals are organized for financial reasons and also waiting time, and it takes a long time. So ideally, you should have a good ultrasound. If you have a good ultrasound, then you may avoid an MRI in all patients, but some patients will definitely require an MRI as well, or a CT.
And then the other question, if we are talking about vulnerability, countries are spending a lot of money for screening, for AAA screening, and comparing, the situation that we are talking about future stroke, which I know that nearly 2 million people are suffering and 1.5 million dying from stroke every year in Europe. Maybe it's reasonable to start screening for prevention, because nowhere in the guidelines it is suggested, but the situation is not so good.
Yeah, well, I am a supporter of carotid screening, at least for high-risk individuals, and it's been a great privilege and honor for me to have published this together with many co-authors around the world. So I think that for high risk, there are certain high risk criteria. It's the same with aneurysm. You don't screen all patients for aneurysm. You have to have a history of smoking, 65 males. I think it should be the same with carotid screening. And actually, there's an article which was published last week in Stroke from a group from Gert de Borst group in Holland, and well, I wrote the editorial for that article, and this suggests that you can actually screen and find patients with asymptomatic carotid stenosis before they give symptoms. Because yes, I agree. For the last 20 years, the numbers have been stable, same number of strokes. Whereas for aneurysm, we know there has been a massive decline with screening. I'm really not sure why we cannot have screening for carotids. I think it will help.
Thank you.
Thank you. Thank you.
Thank you very much for a great presentation. I think we are also for example, in Latvia, we're just starting to speak about the AAA screening, but of course, just like in many countries, there is no carotid artery stenosis screening. Would you say, what are the criteria? Because we clearly know the screening criteria for AAA, but what would be the criteria you would use to select the patients for carotid screening?
Okay, well, age is the first, and smoking history is very important. And also perhaps, if you have vascular disease in another territory, that would be, but on the other hand, of course, if you have vascular disease in another territory, you may be on medication for that, but still, I think it wouldn't hurt to screen.
Yeah.
For the purpose of identifying individuals for, preventive, vascular disease prevention, not for operating on them right away, Yeah. Obviously, if they are on best medical therapy and plaque progresses or they develop symptoms, obviously, it's something you need to reconsider.
And I say that pretty much it also matches the criteria for AAA screening, so maybe the patient can come and do both things.
Actually, actually you can have both. There in the States, I know that there are some screening programs, which are, well, not public, but they're funded, and you do five territories. You do abdomen, carotids, and the coronaries. So there is a screening program.
Okay, thank you.
Thank you very much.
If there are no other questions, then thank you very much, and we could close the session. Okay. Or maybe there is some. If not, thank you very much. Thank you for Professor Tarsello also accompanying me.
Thank you so much. Thank you.
Friends, I'd like to invite to upload presentations for those who will be speaking, not to be in the hurry. Okay?
Hello. This is the moment you see.
Hello, dear friends, again. In the last session, as you saw, it was a small introduction to the carotid session. And now I'm here together with Professor Rytis Kaupas from Kaunas University Hospital Clinics. And I would like to announce that we will starting with a carotid session, and we have a small change. Piotr Milka will be the first presenting his presentation, and other presentations will be as it is written in the list. Yes, Piotr, the stage is yours.
It's from Cosmos. Dear Chairman, ladies and gentlemen, first I would like to thank to Arturas Mackiewicz and Tomas Baltrunas for inviting me the second time, the second my visit in such excellent conference. So it's a beautiful city and absolutely fantastic atmosphere. So I have nothing to disclosure. I try to show you some modification of carotid stenting, but I will start from some truism. It's a truism that carotid stenosis can lead to stroke. That's another one, that's carotid endarterectomy can lead to stroke, and carotid stenting can lead to stroke. And so information that best medical treatment can be ineffective. So our task is to count very carefully all that stroke, select the most effective option, and enhance its effectiveness. So, of course, we observe the progress in all these fields, on these areas. So sometimes it's impossible to compare trials as NASTED, for example, of new ACST2, as because of these progresses, for example, with best medical treatment change, is absolutely different. So such techniques of endarterectomy, maybe not, but stenting is different. But of course, we should look at potential progress. So unfortunately, I say unfortunately because I'm a vascular surgeon, as the biggest potential is in progress in stenting and BMT. And contraindications, okay, so that progress is visible. So the new stents, for example, as mesh stents and new techniques. So, but contraindications are well known, is not changing. So unfortunately, mostly are irreversible. So as well as in carotid stenting. So only few of them we can change. What options do we have in the case of contraindication, both carotid endarterectomy and carotid stenting? Of course, we can do the risky endarterectomy, risky stenting, and withdraw from this procedure and use only BMT. Sometimes it's not very good options, and sometimes we should look at some different procedures or some modification. As an example of this is using a fusion of carotid artery during the stenting for patients with renal insufficiency, and using the fusion road mapping, especially using the MRI without contrast. Of course, difficult anatomy. This is a nightmare for stentors, I can say, for surgeons, cardiologists, radiologists. What's mean difficult anatomy? It's mean there is a way, the road from the access site to the lesion is not straight, or is not straight enough for perform safe procedure. So sometimes we can do something with this, and of course we can use that through technique. maybe not well known, but using, for example, in the complex aortic procedures. So then we can use the brachial and femoral access or carotid and femoral access for strength away from the access site to the stent graft. Of course, we can read some papers about it from the carotid area, just through few case reports and nothing more. So after the brainstorm, the international brainstorm, as the Cosmas is here, we decided to check some modification in some different groups of the patients with difficult anatomy. So why superficial temporal artery? Because it's superficial. We can make this access using the local anesthesia. We can puncture this artery. The way from, as you see, from superficial temporal artery to the ascending aorta is straight. So it's very easy. It was a very low risk of the stroke during this procedure. We use the same medicamentation as in typical carotid stenting. So we see the example of transfemoral carotid stenting using access, the temporal access, for different groups of patients, and the goal of our study was to test this modification for difficult aortic arch, significant tortuosity of common carotid artery, osteostenosis of common carotid dissection. Of course, if we think about aortoiliac occlusive disease, we can't use the femoral access, so we use the brachial access together with temporal. So of course the most important stage in this procedure is using the retrieval loop and to the through and through wire technique, and always use the 8 French sheath, so we can put inside this 0.14 guide wire and neuroprotection, and then stand at the same time in one sheath. So this example of brachial access using the temporal superficial artery access. So this angle, what you see, maybe it's here, yeah. It's I think it's almost impossible to perform that procedures without this modification. On the right side, you see the 2 different guide wires. One is from the neuroprotection. The second one is in external carotid artery. Why we do that? Because during that procedure, we fix the sheath, even if it's in aortic arch, outside of common carotid, so we can safely use the neuroprotection. It's not move, and we can precisely deploy the stent. With pilot study included 10 patients. We divided into 5 subgroups. You see that with the common carotid tortuosity, proximal stenosis, difficult aortic arch, and technical failure before this procedure, aortoiliac occlusive disease. And unfortunately, during this period, we did not have patients with carotid dissection. Maybe it will be as well useful, and all patients had stenosis above the 70% and were older than 18 years. We excluded the patient with fixed hemiparesis and good candidates for carotid endarterectomy. 8 patients before that procedure suffered from stroke, and 2 we operated because of rapid growing of the stenosis. During the observation, we have no death, we have no strokes. Within 13 days, there's a complication related to this modification. In observation, we have the patients after 1 year as well without strokes and TIAs and death. So, in conclusion, this pilot study suggests that performing transfemoral and transbrachial carotid stenting with the support of superficial temporal artery access as a feasible and safe procedure. The critical factor for success is the cannulation of superficial temporal artery. We always use the open access, so our radiologists try to puncture less percutaneous this artery. You know, I am a surgeon, is outside of my knowledge. I never try to do that, but this access open is very, very simple. So the patients with challenging carotid arch anatomy, common carotid proximal stenosis, tortuosity, and patients with the Larish syndrome with aortoiliac occlusive disease, using this superficial temporal access may allow for technical success for such stenting. Thank you very much for your attention.
Thank you so much. Maybe we have some questions, remarks? If no, I'd like to ask. Oh, okay.
Wonderful presentation and congratulations for your results. I have one technical question. When you are performing that kind of operation in a very sharp angle, then you need to pull a little, to give a little tension on the angle of the artery. Are you afraid of dissection in this region, or did you face it, or do you have any protocol to check whether it appeared or not?
Okay, Tomek. Of course, it's not visible because this figure it's not very detailed. So we always use first the 0.14 guide wire, and then always for French hydrophilic catheter. So for protection of dissection, the cutting, you know, it's a cutting of this artery. This dissection is like decapitation of the rattles and kill them. So yes, we always use the very, very, very small hydrophilic catheter, always, almost to the end for protect these arteries. All these angles is away from superficial to external, from external to common, and especially from common to aortic arch. So we have the more procedures. I think that's it's a very useful procedure, for example, for occlusion or thigh stenosis of brachiocephalic trunk. It's not easy to use the neuroprotection if we have the thigh stenosis of this one. So it's always risk of cutting the aorta using such. As I told you, we use these catheters.
And if I may, one more technical question. You're doing it in local anesthesia, everything?
Yeah.
All right.
Always in local anesthesia, yeah.
It's not painful for patient, no?
No. No, answer is simple. Of course, it depends on, I can say, sensitivity of patients. Generally, the pain is like if you made excision of some skin changes, yes, because this area is a little bit painful. So if you use the local anesthesia, the moment of anesthesia is painful, but the next stages are without any pain, painless.
You always perform distal protection in those cases, yeah?
Yeah, always we protect, always distal protection. Why? Because of course we can try to use the proximal protection, but I can tell you that we have no enough good experience with proximal protection. So we used this protection as a MoMA or parody the years ago as just only in a few cases, and we don't want to risk that we will have some complications related to proximal protection, not from this access. So we used this distal protection as we use usual. So
trackability, probably the MoMA device is not so good.
Yeah.
Okay, thank you so much.
Okay, thank you.
We will move to another presentation. Dr. Bulbula about restenosis rates following endarterectomy and stenting, new results from ACT2.
Great. Thank you very much, Arturas, Thomas, for the kind invitation to this meeting. It's a pleasure to be back in Vilnius. I had hoped to give you a world-first presentation of these data. Unfortunately, it was presented a week and a half ago in Krakow at the ESVS, but this is a world-second presentation of these data, looking at rates of restenosis in a large randomized trial, ACST2. No disclosures, and the British Heart Foundation funded much of this long-term follow-up work. For those of you who may not be aware, in ACST2, we randomized 3,625 patients to carotid surgery versus carotid stenting. The take-home message from the 5-year results of this randomized trial was that the rates of fatal and disabling strokes were almost identical in surgery and stented participants. But in carotid artery stenting, we did see an excess risk of non-disabling strokes. Almost all of these were peri-procedural. We're carrying on following up all ACST2 participants, and we hope to share 10-year follow-up data this time next year. And really, if you were going to choose between a surgery or a stent, and if you were a patient, you'd really like to know what the 10-year durability of these procedures are, not necessarily the 30-day or 5-year data. Because once an operation is done, it's done for life. But whilst we're waiting for these 10-year data, we thought it would be reasonable and interesting to look at rates of restenosis in those patients in ACST2 who had a procedure, because restenosis might be a useful surrogate efficacy measure for the durability of arterial repair. So the aims of this restenosis study were firstly to look at the frequency of restenosis in those randomized to surgery versus stenting, and also to look at the long-term risks and clinical significance of restenosis. This morning, I'm just going to focus on aim 1, comparing the rates of restenosis, because we don't yet have complete follow-up for all our participants. So aim 2 might be Vilnius 2026, I suppose. So how do we do this? In ACST2, we had a standardized protocol. Everybody who was randomized and had a procedure returned a 1-month form where the operating surgeon or stenter described procedural hazards, stroke, myocardial infarction, and death, and also provided a 1-month post-operative or post-intervention carotid duplex scan. Thereafter, patients returned annual postal questionnaires describing any recurrent strokes, any redo carotid procedures. In the restenosis study, we also had the ability to capture post-operative surveillance duplex scans, which were part of routine clinical care. These duplex findings were provided by the centers who did them on a standardized form, and the data on the form were interpreted by an expert independent neurologist to classify them into degrees of stenosis. So of the 3,625 patients who were randomized to CAS versus CEA in ACST2, almost everybody had a carotid procedure, and almost all of those had a post-procedural duplex scan. So that's the data we're looking at for residual stenosis. For restenosis, about 2/3 of ACST2 participants had post-operative duplex scans as part of their routine clinical care, and they contributed to this restenosis study. So first, looking at residual stenosis. So these are early, stenosis still apparent around 1 month after the carotid procedure. So almost everybody contributed to these data, and rates of residual stenosis were pretty similar for CAS and CEA. 4% moderate stenosis for CAS, 3.3 for CEA, slightly higher severe stenosis for CAS than for CEA, but no significant difference between these two groups. Looking now at restenosis, our fundamental aim is really to capture restenosis rates after 2 years, because that's probably when the arterial repair is stabilizing. But obviously, when we inquired about restenosis rates, we got lots of data between 0 and 2 years as well. So rather than discard that data, we just included it as well. So in around 300 patients, all we've got is restenosis rates at around 1 year. And those are slightly higher for stenting than for surgery. But after 2 years, where we have most of the data, 1,500 patients, the rates of restenosis are really pretty similar between both groups. And indeed, the numerical difference with a higher frequency of CAS restenosis than CEA restenosis is not statistically significant. But when you combine any restenosis, the early and the late, there is a slight significant excess risk of restenosis in the CAS-treated group than the surgery-treated group. But again, small numbers, not complete data yet, and only marginally significant. So I wouldn't make too much of a fuss about these findings. What about the clinical consequences of restenosis? Well, let's first look at the risk of restenosis with subsequent stroke. The caveat here, and perhaps the only take-home message from this slide, is that the risk of subsequent stroke is low. Yeah, we had 4 strokes amongst 80 patients who had a restenosis detected at 6 months to 2 years. And we had 12 strokes in total from 6 months upwards, with a median follow-up of around 4 years. So stroke following restenosis is infrequent. Next, looking at restenosis leading to a redo procedure. So this was commoner than stroke. In restenoses that were detected up to 2 years, almost half of these patients underwent a redo procedure. Most of these were not, however, driven by symptoms. And if you look at any restenosis detected with a median follow-up of 4 years, around 1/5 of patients with a restenosis underwent a repeat procedure, the vast minority of which were driven by symptoms. So if you are to do a redo procedure, what was happening in ACST2? Well, amongst those first treated by CAS, by far the commonest redo procedure was another CAS. Amongst those first treated with surgery, and even more of those patients had a redo CAS, not redo surgery. So CAS would appear to be the treatment of choice for restenosis in ACST2, and that probably aligns with routine clinical practice and guidelines as well. So putting it all together, I think the rates of restenosis are low in ACST2, but slightly more frequent in CAS, but that's driven by the excess we see at 6 months to 2 years. It'd be nice to see what happens when we have more 2-year data. Reintervention is relatively infrequent and, importantly, not normally driven by symptoms. The clinical significance of restenosis overall and for CAS restenosis versus CEA restenosis is yet unclear in ACST2, but I hope that with longer follow-up and more duplex scans, we'll be able to shed more light on this critically important question. Thank you very much.
Thank you, Richard. It's very nice to hear that it's second time in the presentation, and I'm happy that it is in Vilnius. Yes, maybe we have questions. Piotr, want?
I could feel this one coming.
Piotr, can you switch on mic?
Better, worse? Maybe I would just, okay, I can just speak loud. So thanks so much for taking this exercise, very important data. One issue that I may have missed is the velocity threshold for non-stented versus stented vessel. We know this from SPACE-2 trial that the same velocity threshold is not applicable to stented and non-stented artery. Did you have one threshold for both CA patients and CAS patients? Also, we know that in-stent restenosis is dependent on the stented design. I think Lucas will be talking about this in the next talk. But for instance, wall stent has 3-fold greater restenosis risk, the double-braided design, than some other stents. So it will be important, as the next stage, to marry this presentation with, I know we are looking at the stent types used in the study too, because this may have some more information. I'm not sure it's so easy to say, that's more or less, because to say that to compare the restenosis with the two treatment modalities, you would really have to look at CTA or DSA scans, which of course are are non-applicable to this population. So I think it's an important insight, but not necessarily definitive information. Yeah. Thank you.
Absolutely, Piotr. I mean, it's not perfect, but it's the best that we could do. First question, classification of degrees of stenosis. We use the same thresholds for both surgery and stenting, and that was driven by Leo Bonatti and Benjamin Wagner, who was his research fellow, and that's the approach that he used in ICSS. But I do accept that we're maybe comparing apples with oranges. I do accept that. That's a very valid criticism. Your point about stent types is really valid. So the wall stent was the commonest stent used in ACST2. And so probably what we're looking at here is a mixture of first-ish generation carotid stents and a smaller number of second or third generation carotid stents. But ACST2, as you know, was a strategy trial. Operate any way you like as long as you do it well. Stent any way you like as long as it's done properly too. But yeah, that is a criticism. Yeah, it would be very nice to look at the broad categories of stents used, but you run out of statistical power when you do that. But we'll certainly have a look at it because it's a very valid point, particularly for the second generation stents, the mesh-covered stents. The more burden you have inside the artery might predispose to restenosis. Well, of course, Piotr, you are the king of post-dilatation, aren't you? Yeah.
Thank you, Piotr. But as I understand myself being a surgeon, it's not equal to compare a month ago after stenting and after endarterectomy both arteries, because, okay, if we're speaking about restenosis after stenting, it can be because of stent, something other problems, calcium, and when you're talking about endarterectomy, that means that are technical problems. Yeah. That is not atherosclerosis, not pseudo-intima, that we're speaking about technical problems in the month.
Yep. So I think it's really important to split residual stenosis apart from restenosis. And indeed, things happen in the artery up to 2 years, I think. So probably after 2 years, you're getting later, a true picture of what the long-term durability of the repair is likely to be.
Okay, thank you, Richard. Thank you. And we're going to the next presentation. Unfortunately, Lucas Tekele cannot arrive, but we have a recorded presentation. Maybe I would like from the friends from the company, can you hear? And to present that presentation.
Hello everybody, thank you for the invitation. I hope you enjoyed the meeting. My topic for today is carotid in-stent restenosis. This permanent narrowing of vessel diameter greater than 50%, and for severe restenosis this more than 70% of lumen reduction. We must remember that nested criteria cannot be directly translated into duplex Doppler evaluation as it is based on velocities measurement. In this systematic review, we can see that different groups use different diagnostic criteria for more than 70% restenosis, and that, of course, may influence the incidence of restenosis. What is also important, only 43% of restenosis were confirmed by angiography. That means that the number of false positive or negative results is unknown. Other factors that may influence the restenosis is differences in elasticity between native and stented artery and stent type. This is a summary of several meta-analyses showing that long-term restenosis rate is as high as 10%. We must remember that this is first-generation stents. In a lot of cases, the post-dilatation was not mandatory and stent implantation was suboptimal. In our group of 2,600 stented arteries, including 92% of first-generation stents and mandatory post-dilatation, we have 3.6% of more than 50% restenosis detected by DUS and 2.0 restenosis with more than 70% lumen reduction confirmed in angiography. The time from initial angioplasty to first restenosis were about 2 years, and more than half of cases occurred within first year. What about guidelines? Only ESVS guidelines address the issue of restenosis. They proposed those thresholds for diagnosis, instant restenosis, and they indicate to perform intervention, CAS or endarterectomy for symptomatic more than 50% instant restenosis, and for patients who develop focal neurological symptoms during angioplasty with proximal neuroprotection. There are different types of treatment for instant restenosis, but mainly it is repeated angioplasty with stent implantation or balloon angioplasty. The same situation is in case of recurrent instant restenosis. Please note that only 4% of patients developed recurrent restenosis. In our group, we used mainly drug-eluting balloons for angioplasty. And this is a case of asymptomatic patient with gradually increasing instant velocities 12 months after initial angioplasty. We can see here the angiographic confirmation of severe restenosis in road saver stent, and it was confirmed by IVUS with MLA 3.4 square millimeters. In VH, we have neo-intimal proliferation. This patient was treated with drug-eluting balloon 5.0, and the patient tolerance of occlusion for 60 seconds was good. This is final angiography and minimal lumen area of 12 square millimeters evaluated in IVUS. This is another patient with recurrent instant restenosis that occurred 6 months after first balloon angioplasty for restenosis. We used in this patient Zotarolinus eluting stent 4.0 by 24, and we can see here immediate result and very good result in 12-month follow-up. There are several risk factors for restenosis, including older age, female sex, smoking, diabetes mellitus. However, there are also other risk factors, in some cases perhaps more important, related to procedure like stent under expansion, stent artery mismatch, lack of post-dilatation, or non-optimal angiographic result. It is also worth to notice that in general population, there is 14% of people with hypersensitivity for nickel, which may also influence the risk of restenosis. In our group, bilateral and high-grade stenosis were independent risk factors for restenosis. And what is more important, initial carotid wall stent implantation was a risk factor first and recurrent in-stent restenosis. Is in-stent restenosis benign condition? There are in general two mechanisms of first generation stents in-stent restenosis: early, which is neo-intimal hyperplasia formation, and it is usually benign. And for late restenosis, it is in-stent progression of atherosclerosis, and this one may be symptomatic. We have found three types in VH study, three types of restenotic tissue component. First one, fibrofatty, which equals neo-intimal proliferation. The second one is diffuse inflammation, TICFA-like. And the third one, instant growth, neuroatherosclerotic growth of plaque. This is an example of a patient with multi-level atherosclerosis who developed in-stent restenosis about 10 years after initial carotid stenting. Firstly, it was symptomatic, but several months later, he developed crescendo ipsilateral transient ischemic attacks. He was urgently admitted to our hospital. In direct angiography, the severe restenosis was confirmed. You can see the very irregular plaque here, and virtual histology showed large big confluent necrotic core areas in direct contact with the vessel lumen. After predilation with the undersized balloon, the stop flow phenomenon occurred, and it required first aspiration with the aspiration catheter, and then removal of the filter in half-open configuration. It led to flow restoration, but some protruding plaque fragments are here visible. After insertion of the second filter, Seagard 8 by 40 millimeters was deployed and post-dilated. And we can see here the angiographic very good result with no visible plaque protrusion in IVUS. The patient has remained asymptomatic, and this is a 5-year follow-up CT showing very good result, and this is ultrasonographic result. The restenosis rate in second-generation stents. In our group of 300 CAS procedures performed with road saver stent, the 12-month restenosis rate was only 2.3%. However, Adam Mazurek, in his systematic review, showed that restenosis rate of road saver may be as high as 7% in 12-month observation period. This is an example of immediate OCT evaluated result of road saver implantation. We can see here some plaque prolapse, but very gentle. In this panel, we can see these are the images from our colleagues from Japan. The immediate plaque protrusion within the stent and the plaque protrusion which is delayed several days after stent implantation. In this panel, we can see the typical restenosis in road saver, and in those two pictures, we can see unusual restenosis with separation of the stent frame and mesh with some tissue formation inside the detached mesh layer. This is OCT result of C-guard implantation. We can see here some plaque prolapse, but it is covered by mesh. This picture shows us 2-month follow-up in OCT with very good result. Some endothelialization. And in fourth panel, we can see 5-year result and result after 6 months with high endothelialization that is maintained after 5 years. And this is data from yesterday in our group of more than 500 C-guard carotid arteries stenting with routine post-dilation optimization. We could find only 2 instant restenosis, giving the number of restenosis less than 0.4% in 12 months. In conclusion, incomplete atherosclerotic plaque coverage with first-generation stent may be associated with instant atherosclerosis progression. The vascular management of instant restenosis resulting from neoatherosclerosis progression may be associated with cerebral embolism. Micronet-covered stent implantation followed by high-pressure balloon optimization enables plaque insulation with optimal long-term outcome. Micronet-covered stent restenosis rate is low, less than 0.4% within 12 months. Thank you very much.
Unfortunately, we are moving off time, so please be invited, Dr. Piotr Musialek, and talk about highly calcified carotid lesions.
Good afternoon. It's a great pleasure to be here. Thank you so much. It's especially a great pleasure to be coming back. What we would like to do is to take you to the operating room for this coming 10 minutes or less than 10 minutes a bit. Can we please have the video? So I thought that this is Krakow that many of you visited last week for the ESPS. One in a series of patients. We are now approaching 1,000 patients. Non-selective with increased risk of stroke. Similarities to Krakow. Good morning. We are in John Paul II Hospital in Krakow in cath lab number 4. With me is Adam Mazurek, who's been investigating highly calcific lesions for several years now. My name is Piotr Musiałek, and with us is also Professor Pieniążek. We have a 57-year-old patient, a lady, who had a left hemispheric stroke 6 days ago. The stroke manifested as severe aphasia, total paresis of the right arm, and partial paresis of the right leg. The patient was diagnosed with a left carotid artery stenosis. The lesion is highly calcific on duplex imaging. So this is a patient after recent stroke, tight stenosis. You can see the recent stroke on the CT, and also MRI shows multiple foci.
The patient had in 2008 surgery for cancer of the basis of the tongue, and that was followed by radiotherapy. Okay, so this is the two contralateral projections, the two contralateral angiograms. We can see a severely or very severely calcific lesion in the proximal portion of the bifurcation, and distally a tight, like more normal carotid lesion. Okay.
So this is a tandem lesion, yes? This second lesion is more like a normal lesion. You can see extreme calcium at the ostium of the symptomatic left internal carotid artery, meeting all the criteria of an extremely calcific lesion. So this is grade 4. So this would be for surgery, but you see this pergamene-like skin here, and this is post-radiotherapy patient. This is our procedural strategy.
There's flow reversal from the external and from the internal going to this catheter in the common. So I will now deflate the balloon. We have proven that we have proximal protection that is operational, that is working, because we've decided we use double protection in this case, yes? We don't know how long the patient will tolerate flow reversal. This stroke is likely to have had a hemodynamic component, so we want to make sure that then when attacking the calcium, there's also a basket that will pick up the debris, preventing cerebral embolism.
So this is not a
I'm trying to cross the lesion under flow reversal. Looking for the channel. This looks good. I will take some support from the balloon. We have an active flow reversal. You can see the blood is coming from the brain here out. Okay, super. So as you see, this inflation is performed under proximal protection. You can see the backflow of the contrast to make it safe, yes? Okay, so what we now have to make sure, we have crossed under proximal protection. We have also made a channel for the spider filter, mini catheter, delivery of the spider filter. Now we have to make 100% sure that we are in the true lumen distally. So we will inject and reverse, Adam, okay? Mm-hmm. I will again now, can you give me blood pressure? Okay, so I'm reinflating the flow gate now. Can we see the tip of the balloon? Pani Adamie, góra balonu, okay. Okay, injection and reversal. Perfect. Perfect. Okay, so we now know we are in the true channel. You can see the backflow. Yes? And Dr. Mazurek is now delivering the spider filter on which he made a J at the tip of the wire.
The balloon is inflated.
So this is the IVL balloon.
You see the spikes of the ultrasound energy now, yes, on the screen. Very nicely presented.
Okay, 10. Yes, I deflate the balloon. The blood pressure is okay.
10 spikes per cycle, yes?
Yes.
And you can perform
go
up to
forward,
10 of those.
So this is equivalent to 50 atmospheres, making mini cracks.
Yes.
You go a little forward. We see the, now I put 4 atmospheres.
So we are now under double protection.
You see the balloon, and we start again the second application.
Please observe the ECG now.
This click, 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 click. This is the ultrasonic wave.
And it's no reflect with blood pressure dropped and some kind of bradycardia, so I'm very happy that this is so safe procedure.
How many pulses now? 10 pulses also?
10 pulses in high pressure, go down, go down.
So it's number 2.
Now will be number 3. I give the 6 atmospheres. Okay, the balloon is inflated and we can go forward. Application.
So this is series number 3 now.
Number
you see
3.
10 pulses of the ultrasound wave energy.
Okay. Go down, deflate the balloon. Yes, and go down, 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 down. Okay, I inflate the balloon.
Okay, now you're in the middle of the lesion.
8 atmosphere.
So inflate the balloon and trigger the spikes of ultrasonic wave. So this was our choice for the stent. There's a randomized controlled trial powered for DWI lesions that shows profound reduction in the amount of
as you can see, the stent is flashed, yes. Now, Adam, please show the trick, what we do when we introduce the stent. We introduce also saline here to have backflow of the saline, not to introduce any air in the system.
Now we are crossing the lesion with the stent.
You see, very smooth passage.
Very easy.
A bit too high up.
Very
now,
easy.
see, Adam is opening the valve. Show it again. I'm pushing contrast through to have backflow of the contrast. Want to beware of air embolism. Air embolism is very symptomatic. It totally resolves usually, but it's important to avoid it. Let's inject.
On the left, you can see the lesion after preparation with IVL.
Okay.
Okay, let's stop. Now we can inject again. We can check the position of the stent.
Okay.
What do you think about the position of the stent? Are we okay, Adam?
Perfect.
Happy?
Perfect. Perfect.
So it's perfect for you, but responsibility is mine. Record.
So you can control, this is controlled
Perfect.
stent implantation.
Okay. Okay. Be careful with the filter. Adam is controlling the filter position. Now we post-dilate, we inject, and we post-dilate the stent. So the distal lesion, I think, is covered now. Yes, we covered both lesions. We'll now optimize, going up to 10 atmospheres here distally, 12. Open the distal crown, Adam. Let's open the distal crown, 10. Now, angiographically, the result is good. With this 5.0 balloon post-dilation, we just still optimize the proximal portion of the stent with 6.0. So now we're doing an IVUS run from the distal
so 6.0 non-compliant balloon
through
at
the
20
stent.
atmospheres.
You can see the stent is rounded. It's very nicely opposed. And it's very nicely expanded. So now this is final intracranial angiogram. Oops, perfect.
So you see, we combined novel techniques in this case, optimized protection, double. We can discuss why this is not the case for MoMA, cracking of the calcium to change a non-compliant lesion into a compliant lesion, optimal stent type to exclude the plaque with an optimal endovascular reconstruction. So you can use this energy to crack your stones in the kidneys.
Without any problems, yes, without any complications. Yes, okay, you see Andrew still here. Dzięki jeszcze raz bardzo. Dzięki Marek, dziękujemy Adam, dzięki Mirka, dziękujemy wszystkim.
So thank you so much.
Thank you, Piotr, so
welcome
much.
to the future.
Yeah, for me it was a great pleasure to see two presenters at once on one stage, two Piotr Muszaleks. Piotr, can you say that we now conquered the last frontier, calcium for stenting?
But there is always a next frontier after you think that you've conquered the last.
Behind that frontier is the next one.
But I think, you know, the serious question one needs to ask, if you can do those procedures in patients who are not candidates for CA, because in our study, if not for IVL availability, this would be a CA patient. We sent very few patients to endarterectomy, but we do not think that CA is dead or has no future. It has future. There's always patients who can be treated with both methods. The issue here was that the patient was not suitable for CA. Our surgical colleagues did not want to treat this patient, and I show you that image of the neck after the paper-like skin, and this is patient after radiotherapy. Most of our colleagues and you here do not want to touch those arteries and those lesions. And the patient required treatment. There was no question whether you can leave this patient untreated or not, because this was a recent stroke and another stroke imminent. So the question is, if you can use this technology to treat those patients who are not suitable for CA, why not use this technology in some of the patients who can be treated with both methods? So there's an issue of price, of ability to use optimized cerebral protection. That is also something that Piotr Myrcha mentioned at his talk. I think that the common space is very large for the two methods of treatment. I think what Richard has showed us was very reassuring. No signal of something really bad happening in terms of ISR, instant restenosis, with the two methods. So it's just to tell you that, there is a frontier we have crossed. There's a lot of interest in the world in IVL. The company was sold, remind me to whom? To Cordis, I think. They are now preparing a dedicated carotid system, and I know there's a trial, FDA trial in the States being planned very soon. So we'll hear more on IVL in carotids.
Thank you, Piotr. And for next presentation, I want to invite Kosmas Paraškevas. He will present about asymptomatic carotid stenosis and cognitive impairment. Thank you, Kosmas. Stage is yours.
I sent you an email, yeah, both of them. Maybe you downloaded only one? There's two. Maybe you downloaded only one. It was for tomorrow. It's today. We'll move on, let's move. You want to continue?
I think the Cosmas presentation is not fully uploaded yet. So
okay,
if you allow, we move on
yeah.
in the interest of
yeah,
lunch and coffee and conversations.
Show must go on.
Okay, so if we could have my talk uploaded, not the video, by the talk. What I've been asked to prepare for today is some more information about the new generation carotid stents, what they are they changing the field, will they change the proportions of patients we'll be treating with using the endovascular pathway. Probably I need to, no, I cannot see my talk, I'm sorry. So we really need you. Do you have another pointer maybe?
What pointer? This one?
This is not working.
No, it's not going to work right now. So where is yours? Not here? No?
No, we uploaded it over there.
It should be here.
It's not. We checked the folder over there. Just need to check the folder.
Not here?
This is Musialek, no. Okay, I think the two computers are not fully talking to each other. Who's after us? So we can maybe move on with.
In the line it is Arthur's, but I don't. Will he succeed to find his presentation if something is happening? Can I understand?
Yes. You see yours? Yes. Okay, so fine.
Hello, I'm happy to be here, and thank you for having me. And today I'm planning to present early and midterm outcome of stenting versus endarterectomy for arterial carotid stenosis. Yes. Natural history, shortly, most common sites, carotid bulb, proximal internal carotid artery, accounts for 10% of ischemic strokes. Atherosclerosis risk factors includes diabetes, hypertension, smoking, increased age, family history, diet and physical activity, and align with the cardiovascular and stroke risk factors. Okay, imaging advanced considerably in the last 20 years. First is carotid ultrasound, best tested for screening, progression and recurrence of disease, evaluation of the disease as etiologic factors for TIA, and also surveillance after CAS or CIA. MRI, mainly used in screening, intracranial collaterals you can find. CTA, stenosis measured by NASCED and SCED criteria, anatomic features such as level of the stenosis, degree of calcification, high sensitivity and specificity for detecting total or near occlusions, and cerebral angiography, most specific yet most invasive, doesn't show thickness of the plaque. Note for trials supporting interventions. First is North American symptomatic carotid trial, European carotid symptomatic trial, and asymptomatic carotid trials, which all shows that carotid endarterectomy is superior to medical arm. But you should take in mind that at that time, medical arm consists only mainly by aspirin. And there is, I mentioned a few trials, CAS versus endarterectomy. First is Sapphire trial, what shows that CAS is not inferior to endarterectomy. And CREST, what shows that endarterectomy show more myocardial infarction, but CAS show more strokes, and CAS is more favorable CAS is more favorable for younger patients. And CREST-2, what is going on, and hope it will end in 2026, what shows that it's interesting that there is two groups, CAS versus medical management and CIA versus medical management, and that is more precise, I think, to evaluate the final result. It was also mentioned these trials, of course. Carotid endarterectomy candidates, it's from 1951 already. Low-risk surgical candidates, few cardiac and pulmonary comorbidities, anatomical favorable, concentric calcified vessels, lesion at cervical C3, C4 level, below mandibular, several carotid artery tuberosity, and type 3 arch. Sufficient distal collateral vessels, you should always take in mind, maybe it's not strict, but it's good to have anterior communicating artery and posterior communicating arteries, and better results for older patients. Stenting candidates, anatomical features above cervical 3, below clavicular, prior neck radiation, as previous speaker said, or endarterectomy with restenosis, contralateral occlusion, tracheostomia, contralateral laryngeal null palsy, and also high cardiac risk patients, congenital heart failure 3 or 4, ejection fraction less than 40%, unstable angina, recent myocardial infarction, and severe chronic lung conditions and end-stage renal disease. So here is the pictures. You can see here is a coronal axis for CT angiography. You can see the level and severity of the lesion. Next is the same patient, cerebral angiography before stenting. Next slide shows the same patients after protection filter is implanted. And the last slide shows the same patient after stent implantation and post-dilatation. Oops. So, the aim of our study was to assess the benefit and risk of carotid endarterectomy versus carotid stenting in people with asymptomatic and symptomatic carotid stenosis in short-term and middle-term period. We retrospectively reviewed outcome of patients in ongoing CAS, 28 patients, and ongoing endarterectomy, 100 patients for asymptomatic and symptomatic carotid stenosis at our institution on year 2020 to 2021. Patients were chosen according CTA scan, and we use NASCET methodology. All patients receive dual antiplatelet therapy at the day of operation and 6 months after operation. CAS was always done by wire protection device and post-dilatation, and endarterectomy was performed by general anesthesia, mainly by using Pruitt-Tinahara intraluminal shunt and by patch. Data was collected straight after operation and 36 to 48 months after the operation. It was revised, coded, analyzed by SPSS 26 statistical program. This histogram shows age distribution by CAS and endarterectomy patients. You can see the most of patients were in group from 70 to 80 years old. And here you can see the gender distribution in CAS versus endarterectomy. The most were men. Early results, 1 minor vertebral basilar stroke, 4 minor puncture site hematoma. For endarterectomy patients, there was intraoperative stroke. 1 patient had surgical wound hematoma. And we found that endarterectomy was performed statistically significant over CAS in symptomatic patients. No death or myocardial infarctions was found, and CAS from our group was 22% from study population. And midterm results, 7% patients were lost to follow up, 30% died. From alive patients, 25% still smokers, 7% did not use pharmacological agents, 58 did not undergo regular CTA or ultrasound scans for control. We did not find any correlation between age and mortality, percentage of carotid stenosis and mortality, CAS versus A, and mortality, symptomatic, asymptomatic stenosis and mortality in between other analyzed variables. And conclusion, our experience showed compatible short-term and mid-term results, comparable short-term, mid-term results for carotid artery stenosis, CAS and CA patients. There were no difference between single variable and mid-term outcomes following CAS and CIA, and CIA was performed with statistically significant prevalence in symptomatic patients. Thank you for attention.
Thank you, Arturs. I see that we are a little bit out of time. I would like to invite next speaker, Then we're again starting with Cosmos in the line. Yes, please, Cosmos.
All right. Good afternoon, everyone. Thanks again for the invitation. Come to Vilnius, really appreciate it. So I will talk about asymptomatic aortic stenosis and cognitive impairment. Now, this was an invited review article from the Journal of Cardiovascular Surgery, and I was fortunate enough to be joined by a nice group of people. So essentially, we performed a systematic review, and essentially we were left with 49 studies. What we found was that one of the reasons for cognitive decline in patients with asymptomatic aortic stenosis is cerebral hypoperfusion. So as we all know, the brain has the autoregulation, and as as the carotid stenosis progresses, there's cerebral hypoperfusion. We have a maximal dilatation of capillaries, of cerebral capillaries, but at some point, the capillaries cannot dilate any further, and that's when we have exhausted cerebrovascular reserve. And that's one of the mechanisms that accounts for the cognitive decline seen in some patients with asymptomatic aortic stenosis. The second mechanism, which is also prevalent, is the silent cerebral embolization as a cause of cognitive decline. So actually these patients, they're not asymptomatic with the proper use of the word. They have some cognitive decline because of this microemboli, and we have deterioration of cognitive tests, and this because of this emboli, and this can be detected with TCD. And that's the second mechanism involved in the cognitive decline seen in patients with asymptomatic aortic stenosis. Now, it's very interesting that some patients that come, I mean, I have operated on many patients with asymptomatic aortic stenosis, and then 6 months later, their spouse comes or the wives come around and say, "Doctor, he's much brighter." I mean, they observe it as well, that their cognitive function improves after endarterectomy. And I've seen that. I'm sure many of you have also seen it. And it's worth offering these patients carotid endarterectomy to improve their cognitive function. In fact, the ESVS guidelines do not agree. They say that cognitive decline is not a reason to offer carotid endarterectomy in these patients. And actually, we did this systematic review with Professor Ross Naylor a few years ago. Actually, we did that review for the guidelines, for the 2023 ESVS guidelines. We included 35 studies at that time, and in 33 of the 35, there was an association between asymptomatic aortic stenosis and one or more tests of cognitive decline. However, as Professor Naylor said, an association is not necessarily a causative one. So it doesn't mean that asymptomatic aortic stenosis is a cause for cognitive decline. But I think that, if the majority of studies show an association, it's pretty reasonable to assume that there is a causal association between the two, although there is no proof, obviously. But anyway, the mechanisms involved in these cases were also the same. And then, as part of these reviews, a second systematic review was undertaken by the same group, and this included 31 studies. but it showed mixed results. So there was no definite data from the literature that you know, an endarterectomy or stenting improve cognitive function. And in line with these, the guidelines provided a recommendation that against carotid intervention for the prevention of cognitive impairment. That was based on these two reviews, and that's present in the guidelines now. So it's true that the findings from the literature are mixed, and because of this, there cannot be any stronger recommendation for an intervention to prevent or to reverse cognitive decline so far. Thank you all for your attention.
Thank you, Cosmos. As I understood that Alison and Richard study conquered your study in the guidelines, because I remember that Ross' presentation, again from that your article. But the question is, maybe we are not using the correct cognitive tests for the patients.
Yeah, it could be. Could be, yeah, you're right.
Not at the correct time when to use them, because I have read that maybe 2 years ago in USA, started a big study for cognitive impairment, and especially for Alzheimer's disease with asymptomatic carotid artery stenosis.
Yeah, I think actually CREST is looking into it as well. CREST 2. Is that? CREST Hemodynamics and.
Yeah, Richard, please.
Hi, Cosmos. Great talk. Yeah, CREST 2 is looking at this in perhaps a more precise fashion than we were able to do in ACST 1. So it'll be interesting to see that. But as you said, Arturus, studies like this need to be very, very, very long, because stopping dementia, it's a bit like stopping a supertanker. It probably takes a long time. One small thing we did see in ACST 1's dementia study, which I'm not really allowed to talk about because it was tiny numbers, post hoc, et cetera, was that in the small number of patients who had normal brains before carotid endarterectomy, we did see a suggestion of protection against dementia. So perhaps if you get in early, prevent silent brain ischemia, you might actually help reduce cognitive decline. But it's speculative, and I think it'd be very interesting to see what a large, long study would show.
Because me, myself, I had a patient, a young patient for carotid artery stenosis, 60 years only old, and the disease was Alzheimer's disease, and neurologists were discussing about that. Is that correct diagnosis or not? I did the surgery. The wife said it's okay. He became on his own, but the cognitive studies for the patient showed other. Thank you.
Yes, sure. Thank you. Thank you.
Please read.
Please. So please, again, second attempt of Piotr Muselek about carotid empty embolic new stents, optimal interventional therapy.
Thank you. So a memory stick has made a difference. So what are those anti-embolic stents mentioned several times today? Are they the same? Do they differ? Is it something that's going to replace first generation stents? Let's have a look in more detail at this question. One of the issues with so-called asymptomatic carotid stenosis is that a lot of people believe put this patient on maximized medical therapy, the risk is low. This is one of actually my patients at the age of 47. I treated the patient for non-ST elevation MI, bad family history, bad atherosclerosis. You can see here this, no, I cannot, you can see about 60% lesion in his right internal carotid artery, a bit badly looking plaque. The guidelines say maximize medical therapy observation. This is what happens several months later. The asymptomatic lesion becomes symptomatic. All symptomatic lesions would have been asymptomatic before. Occlusion of the right internal carotid artery, stroke, fortunately right hemispheric for the 47-year-old. So the question is,
something's going wrong if we just put universally all those patients on maximized medical therapy. Cosmas was talking about vulnerable plaque characteristics. We need to find better ways to select patients who can benefit from intervention on top of maximized medical therapy. So strokes should be prevented rather than experienced. We should not be really talking about treating symptomatic patients because it's too late for those who would have experienced a major stroke. We need to pick them up before. And what the ESC Stroke Council did in 2022 was putting together people from different specialties, from different geographies, from the States and from Europe, to really try to establish a common knowledge base for multi-specialty discussions, because everybody has different guidelines. Cosmas has different guidelines, Andrei Afanasiev, neuroradiologist, has different guidelines, I have different guidelines, but we are supposed to treat one kind of patient. So the treatment of the patient should not be related to who the patient sees. So we sat together, it took longer than we expected, about 2 years, and we really came up with this schematics that shows first, that the patient is in the center. The patient has a decisive role in their treatment. They need to be fully informed. The treatment offered should be multi-specialty guided. So talk to your colleagues. We do talk in our center to a neurologist. We do talk to our vascular surgery colleagues. And then Richard has this concept of the risk spectrum going from low risk to high risk patients. This looks nice on the diagram. Of course, it's difficult to define where your patient is on this spectrum, but this should be our aim. And there's more and more scales coming. Recently, Cosmas wrote an editorial, You Can Go to Stroke, about patients from the REACH registry, looking at the different level of the risks associated with asymptomatic carotid stenosis. And then, you know, medical therapy, of course, is in the bottom, but some patients, we believe, should be offered intervention before they get a stroke rather than after they get a stroke. The risk of procedure is what really shifts the balance in your decisions, because if the risk of your procedure is large, if you also can cause a stroke in an asymptomatic patient, obviously you will be more inclined to use isolated pharmacotherapy. But if the risk of procedure is lower, you will be more inclined to offer the intervention to some patients at increased risk. Intervention obviously can cause stroke, both CA and CAS. And also the type of intervention that you choose would be related to the risk of stroke, death, MI with this procedure. Carotid-related stroke is another very important entity. We believe that those patients should not be treated in 48 hours. It's not a question of belief, it's also a question of data, or in 7 days. They should be treated acutely, as you know, Andrei Afanasiev is doing here in Vilnius with his team by neuroradiologists. And there's novel technologies, ability to remove the thrombus, ability to isolate, sequestrate the plaque, play an important role in treating those stroke patients. With conventional devices in acute carotid-related stroke, the risk of embolism is about 20 to 30%. And the risk of stent thrombosis with conventional stents is also about 30%. So with first-generation devices, the treatment was not so easy. You can see with the second generation, in this case, stent with proper proximal protection. Again, there is no reason to say that this patient should wait for 48 hours or for 7 days when, you know, half of the brain is gone for intervention or no intervention, because many of those patients become ineligible for intervention. We don't see them in any statistics. If they have a major stroke, MRS 3, 4, 5, if they are bedridden, they do not enter any guidelines. They do not enter any statistics. The patients who are in the studies are the patients who are suitable for treatment after stroke. But we are really concerned about these patients who would not have been suitable or who would have died after a stroke. And you can see you can treat the patient safely with good 90-day follow-up. So the problem with CREST-1 that was mentioned today is what I call the primary scene of CREST-1. And that's why really the types of interventions have been discussed, continue to be discussed. This slide continues to come up. The more small strokes with conventional carotid artery stenting, more MIs with CA. The question, would you rather have a small stroke or would you rather have an MI? And the whole discussion that led finally to separation of the combined endpoint. If you do a study, Richard will tell you that you have a predefined statistical power analysis, you have a predefined combined endpoint, and then you take away the composites of this endpoint to prove one or another hypothesis. But CREST is with us. CREST-1 is all the time. When you look at the guidelines are based on the CREST study. The problem in CREST was the problem of first-generation carotid stents. During the procedure, you have the interaction between plaque, embolic protection device, and stent. But then after procedure, the protection device is no longer there, but with a first-generation stent, this is what you leave in a symptomatic lesion in your artery. You can see plaque material coming into the lumen. It can not only embolize, it can also stimulate thrombosis there. So unsurprisingly, if you look at the number of strokes after the procedure, during the procedure, at least 50% strokes by 30 days are post-procedural with first-generation carotid artery stenting. And there is a mechanistic evidence for that from diffusion-weighted MRI studies showing that embolism with first-generation CAS is continuing after the procedure. This is data from CREST. 50% of those difference-making strokes between CA and CAS were post-procedural. This is data from CAPTURE, 40% of strokes, day 2 and more. So the problem with CREST is the problem of the devices that you can see in the bottom, an archaic first-generation filter, an archaic first-generation stent. So it's very difficult to use this data to our clinical decision-making today. We should really look at contemporary evidence rather than at historical data. So this is, again, the first-generation carotid stent. This is the CREST study device. You can see the lumen of the artery packed with plaque material. And unsurprisingly, what Cosmas did with Frank Wieth, in reaction to this first-generation stent data, they said very clearly that in symptomatic patient, CAS is not equivalent to CA. Plaque morphology plays an important role, but we do not say no forever. Once you improve the devices, you come with better cerebral protection, you come with plaque insulation. This will be reconsidered in future, the place of carotid artery stenting. So when we talk about CAS, it's very important to say what CAS we talk about. Do we talk about first-generation CAS, or do we talk about contemporary carotid artery stenting? So the second-generation stents were developed to address this problem of plaque prolapse during and after procedure. There's different designs. You can see here 3 designs that have undergone clinical study evaluation. The Gore device, the Road Saver, which is like a mini wall stent, inner wall stent with connection wires, and the Seaguard, which has micronet, like if you like a sock, put outside to the very open cell stent. We have no time to go into those differences, but these differences is what we believe underlies then the differences in clinical outcomes. This is the Road Saver stent, better plaque coverage, but as you can see here, problems with apposition. This is the micronet covered stent, more plaque coverage. Here the size of those pores in the micronet are similar to the size of the filter pores, the filters that are used for carotid artery stenting. Very open cell structure, assuring very nice apposition to the wall. So this design combines the properties of the most open cell when it comes to the frame and the most closed cell stent when it comes to the micronet size. And this is what the lumen of the artery looks on of the OCT imaging. You can see on your right that here the definition of the struts is very clean. There is no plaque material in the stent. Randomized controlled trial was mentioned already today. This was run by our vascular surgery colleagues, 50 patients in each group, 100 patients randomized to conventional stent, to the Aculink stent, to the CREST study stent versus the micronet covered stent. The study was powered for diffusion-weighted imaging outcome. And you can see here on your left, this is the logarithmic scale, the difference in the embolism to the brain. This is the raw data. And you can see on your right the difference per lesion and also per embolic load to the hemisphere, a profound difference in embolism with the 2 devices, both in this study used under the same type of distal protection. And there's several studies that show that, in fact, mesh stents reduce the incidence of embolic material in the filters. They reduce the filter load, so how much you catch in the filter, and they also reduce CAS-related injury. But what a lot of people are interested in, and certainly those who write guidelines, is show us some clinical outcomes. Yes, we don't want surrogates, we want clinical outcomes. So clinical data is really important. This is data from this randomized study that shows an important signal, hypothesis-generating signal. Here you can see the study did not have power for clinical outcomes. As you know from ACST2, you need a lot of patients to be powered for clinical outcomes, especially if they're about 2, 3, or 1%. So what we performed is a meta-analysis of published trials with first-generation stents and second-generation stents, nearly 70,000 patients here, 45% patients symptomatic. And this is the outcomes. You can see 30-day stroke, 30-day death stroke MI. The red line is first-generation stent. If you go to the right, you are worse. If you go to the left, you are better than first-generation stent. And this is the three designs of mesh stents. You can see that they perform as a group better than first-generation stents, but there are important individual differences. Yes, you can see here that the Gore stent is performing similar to first-generation stents, so it did not really show clinical benefit. Road Saver and micro-covered stent doing similarly well here. The difference comes out at 12 months. If you look at, in particular, at 12-month restenosis, you can see one design being better than first-generation stents, one no different, and one design having more instant restenosis than first-generation stents. This is the double metallic layer stent, and the talk by Łukasz Tekieli showed some insights into why this may be the case. Whether you use closed cell or an open cell stent as a comparator did not make the difference. The message was the same. So what this showed is that there is no class effect when it comes to second-generation carotid stents. There are important differences between the devices, and some designs are definitely better than first-generation carotid artery stenting. What will be even more interesting to this audience, I think, is comparison of second-generation stents with surgery. So this is Carmen meta-analysis of clinical outcomes, second-generation stents versus surgery. What we did here is we pulled data from the recent studies that had a surgical arm, the CA data, and also we looked at the CA data from VQI. VQI has some limitations, has some under-reporting, but nevertheless, that's what's available in the public domain. So here you can see how second-generation stents perform versus CA. Again, to the left is better, to the right is worse. The message, again, is similar to the one you saw previously. There is differences in individual designs. Overall, the stents as a group perform better than CA at 30 days. This is 12-month restenosis. Here you can see important differences. Casper Road Saver, more instant restenosis. The meta-analysis defined rate is about 7% at 12 months of instant restenosis. And as you will see, this is what is confirmed with in upcoming also studies. So important differences when it comes to stent type. Not all stents are the same. But the message similar for CA in RCTs and CA in the VQA database. This is a recent study by FDA. You know that FDA has very tight control of the data. There is an independent adjudication committee. Patients are very closely monitored. We recruited over 300 patients in US and in 5 centers in Europe. The predefined proportion of symptomatic patients in this study by FDA was 25%. You can see more than 40% diabetics, so a really complex population. This is not picking up easy patients for a study. This is complex patients. Different types of neuroprotection used. This was already discussed today. Neuroprotecting general procedures. And when you come to the 30-day death stroke or death stroke MI, less than 1% in this study. Yes. So many operators in the States, they did not have prior experience with using the device. They had not been doing carotid stenting for a long time because you know that only recently carotid artery stenting is reimbursed in the United States. Despite those limitations, less than 1% combined clinical endpoint at 30 days. Now, Richard, please close your eyes. So now let's look at those data against ACST2. I know you'll be telling me, oh, Piotr, you're pulling data from different studies. You should come to our Oxford course, how to do it. And I know I'm pulling patients from different studies. This is the limitation. But the patients in C-Guardians are sicker than the patient in ACST2. And you see 30-day stroke, less than 1% versus 2.4, 30-day death stroke MI, less than 1 versus 3%. So at a minimum, I think, Richard, you will agree with me, this is an interesting hypothesis-generating comparison. 12-month outcomes from C-Guardians FDA. You can see at 1 year, less than 2% of combined endpoint. This also included ipsilateral stroke. By 12 months, 1% of target lesion-only revascularization. This is Road Saver study, European Road Saver study, large study, nearly 2,000 patients. You can see different specialties, surgery, radiology, cardiology, angiology, similar more or less numbers of patients. And this is, here I wanted to pay attention to the embolic protection use. I'm very proud of my surgical friends and colleagues. You can see 80%, 70%, so similar proportion of the use of embolic protection, a lot of embolic protection used by those specialties. Also similar, about 20% proximal protection. MoMA was already mentioned here today. Now let's have a look at the data. Radiology, less than 50% neuroprotection use. 2% death stroke at 30 days, 2.5 and 1.9%. So really to me this is telling that embolic protection remains important with second generation stents. Why? Because the stent mesh would only work after the stent is implanted or expanded. Before that, you need to cover with embolic protection the prior stages of the procedure. Here we took data from different studies looking at microembolic signals in unprotected CAS, filter protected and MoMA protected CAS. You can see, again I have no pointer, but you can see profound difference. Filter helps a bit, but it's the proximal protection by flow reversal, and all surgeons know that you know, you reverse the flow or you make a shunt, you have a safe procedure. So the landscape of carotid revascularization has changed. It is still changing. It will change further when we will have better ways to identify patients who can benefit from intervention rather than just maximize medical therapy. Carotid stent that used to be a problem in carotid stenting in CREST-1 is becoming a protector of the brain. But carotid mesh stents are not created equal. There's important design differences. There's important outcome differences. For the sake of time, I will not go through this in detail. This will be soon coming out in Journal of Sky, looking at some OCT and IVUS imaging. This is one of the mechanical problems identified by colleagues from Japan with the dual metallic layer stents. The layers can separate when you try to post-dilate the device, leading then to further problems. This is the micronet covered stent. This Lukasz also mentioned that this is data from our ongoing study that has external monitoring, that has external CRO, external adjudication committee. So here you can see individual patient data on your left before the procedure. We have about 50% symptomatic patients in this cohort, 533 procedures, 500 patients. You can see velocities at 30 days and velocities at 12 months. Only 2 patients with instant restenosis, 1 silent occlusion. That was occlusion in a patient who reinitiated radiotherapy for thyroid cancer 2 months after CAS, and 1 instant restenosis that was treated with a drug-eluting balloon, as Łukasz was showing you. This is something that we really need to pay attention to. If you choose too small a stent, whatever or however good the stent would be, you are losing, because the stent has malapposition. This cannot be corrected using the endovascular way. The right thing to do is to talk to your surgical colleague, get the stent taken out, because this stent is likely to be a problem in terms of thrombosis and definitely restenosis in this patient. So no device is an excuse for badly performed procedure. We are making a huge difference in acute strokes. This is something that will be developing. It's a big discussion ongoing. Should we repeat the Hermes meta-analysis, the stroke meta-analysis trials, just for the external carotid artery stenosis? It's the same pipe, you know. Does it really make a difference whether the occlusion is here or here or here? It should not make a difference. Some people say, you know, well, we don't have such good evidence. But I don't think it's ethical today to randomize, you know, me or any of you with an acute carotid-related stroke to treatment or no treatment and waiting, then discussing, you know, do we do it at 48 hours or do we do it 7 days or maybe, you know, 30 days or maybe never, yes? So this field is also very rapidly progressing. You need to post-dilate the stent. You need to optimize the stent. There's data showing that if you don't post-dilate or use a small balloon, you have an odds ratio of 15 times on multivariate analysis by loss of patency at 90 days in this very complex group of patients with acute carotid-related stroke. So 30 years ago, Patrick Sorayos and Carlo Di Mario, you know, when discussing the thrombosis in coronary stents, They said it's very important to consider who was thrombogenic. Was it the stent or was it the doctor with suboptimal procedures? So please do not be thrombogenic. Thank you so much for your attention. This is our team in Krakow. We did the first case in Sea Guardians in April, I can see here, 2022. Now, 2 years later, we are already in a different world. Thank you so much.
Thank you, Piotr. I think you convince everyone in the audience to use the stand, to switch if they don't. So there, unfortunately, no time for conversation, and please move forward to the last speech. Dr. Ziebert's ideal patch for closure after carotid adenectomy.
Well, thank you, Arturas, the chairman, and also Thomas for the nice invite to come to this great meeting in this beautiful town. My disclosures, none of them are really related to my topic today, which is all about closure of open-end arterectomy with patches. So the question is, do we really need patches? And I think the guidelines are quite clear about that. Several randomized controlled trials published over the past 2 decades. They compared primary closure with patches, showing that patching was superior in lowering the risk of perioperative stroke and death, and late restenosis. And as a consequence, high-volume surgeons in the US, they increased patch use from 50 to 90% and decreased their 1-year stroke or TR risk from 4.9 to 1.2%, and their restenosis rate dropped down from 9% to 1.2%, and that's actually a huge difference. Now in our center, we used to take the saphenous vein from the ankle, but because of donor site morbidity, we first switched to Dacron, and in a later stage to bovine pericardial patches. And if you compare these two, then there were actually not so much differences, no neurological events differences, but there were slightly more infections with Dacron than with bovine. And also, in a much larger cohort, the differences remained small and actually too small to draw firm conclusions. And also the end conclusion of a recent Cochrane review was that bovine may reduce the risk of perioperative fatal stroke and death and infection compared to other synthetic patches. What to do when the patch actually gets infected? Well, both SVS and ESVS recommend to remove the prosthetic material completely and to replace it by autologous vein whenever possible. But there's no level 1 evidence to support the different approaches. So that's why we conducted a systematic review focusing on the 3 options: conservative, endovascular, and surgical treatment. 30 studies met all the inclusion criteria, and they were used for further analysis. A total of 165 patients we got, mostly with infected Dacron or PTV. Half of them were early infections, so within 4 months after the procedure, and the other half after 4 months occurred. Mean follow-up was about 35 months and not reported in 24 patients. And if we look at the 24 patients treated conservatively, then there were 4 options to do so, but probably there has been underreporting of complications, especially the number of reinfections, and probably only the survivors have been reported. There are some reports of patients treated endovascularly, and there is a series of patients treated in a hybrid manner with covered stents and application of a VAX system, recently updated to 9 patients with good clinical outcome. Then open surgery, mostly a patch excision and reconstruction with an interposition graft using autologous vein, followed by autologous vein patch repair. And results are clearly better than reconstruction with prosthetic material. So, well, this should be avoided, I would say. So, if you are confronted with a case like this from Albany, a 52-year-old male who had a left carotid endarterectomy with a Dacron patch 3 years before, and then came in with a huge, large neck abscess, well, then it's probably wise to clean the field first, use an autologous conduit and remote tunneling, and then thereafter attack the infection. So after the wounds have been closed again and dressings applied, MRSA was cultured here, and he was kept on antibiotics for 4 weeks, and thereafter no further infection. In that case, the previous case, proximally an end-to-side anastomosis was made, and distal an end-to-end anastomosis to the internal carotid artery. And on the right, there's another case in which they went to it directly, and they used an interposition graft with autologous vein. They used an autologous vein bypass. Well, one of the reasons to use a patch is to prevent restenosis. Now, looking at the type of procedure in patients from the ICSS, restenosis was more common after primary closure than closure with a shunt, with a patch, and shunt use had actually no effect on restenosis. So it was concluded that patch closure is a treatment of choice to avoid restenosis. However, as a complication, you already heard it, restenosis may still occur, and this was a patient treated for a right symptomatic stenosis with endarterectomy and venous patch closure, but 8 years later, signs of amaurosis fugax appeared again on the right side, and the duplex showed a restenosis of more than 70% on CTA. It looked actually a bit more like a web. And the patient had a short neck and a high bifurcation, so it was decided to stent it, and 1 year and 3 months later, no signs of restenosis on duplex. So what do the latest ESVS guidelines advise regarding restenosis? Well, symptomatic patients with a 50 to 99% restenosis, they need a reintervention. When the restenosis is less than 50%, then best medical treatment is advised, both level 1 evidence. For an asymptomatic restenosis, more than 70% after endarterectomy, reintervention may be considered, but if this occurs after CAS, then best medical treatment is recommended. And I think for the sake of time, I'm going to skip to the conclusion, because this is a lot about restenosis, and already Richard and Cosmas told us all about that. So if I come to the conclusions, then I would say that using a patch actually is a no-brainer, but the best type of material is still uncertain. When infected, replacement by autologous material should be the first choice, and for restenosis, CAS and endarterectomy, they have comparable outcomes. So I believe the choice of treatment should actually be based on patient characteristics that may influence the outcome after CAS or endarterectomy, such as severe comorbidities and the anatomy of the aortic arch and the carotids. Thank you for your attention.
Thank you, Klaus, so much. Unfortunately, as we all understand, we are out of time. I once again want to ask you for further speakers to upload the presentation before the session. And I want to thank all of you for making a great session. Thank you so much, and now is lunchtime.
Have a good lunch and rest of conference.
gentlemen. First of all, thank you very much for the kind invitation to this beautiful city. I'm the second time in Vilnius, and I'm happy to be here, and I'm happy that this symposium is held in a beautiful place. My topic today is endovascular treatment of aortic arch pathologies. And you all know, or you should know, that for aortic arch pathologies, gold standard is open surgery done in many various kinds, many various prostheses that can be implanted by open surgery. However, we know that the results of those open operations are not perfect. There is a substantial mortality, substantial dialysis risk, or stroke risk. That's why people started to develop endovascular devices for arch pathologies. And this is the first device that I've been used, and the first device that has been launched worldwide. This is arch branch from Cook company. First, it was done with only 2 branches for brachiocephalic and left carotid artery, and then it has been replaced by a 3-branch device for all 3 supraaortic vessels. Obviously, there are special anatomical requirements for arch endografting, especially about ascenic aorta, which cannot be bigger than 38 millimeters in diameter, and it should be parallel and straight, at least 40 millimeters in length, just to seal the prosthesis, to seal the endovascular prosthesis in the ascenic aorta. And talking about the graft itself, it's not a standard graft. It's not a standard tube graft as we know from all thoracic or abdominal devices. It has a lot of very advanced techniques, including this one, which is very important, spiral stabilizing wire. The most important thing when you open the aneurysm in the arch is to open it in good position, good clockwise position, and it cannot be done just by rotating. You cannot rotate graft in the arch before opening it, because it's stable in the arch, it's stable in the curve. So that you need this stabilizing wire so that you are sure that the graft opens with the branches opening on the outer curvature, otherwise we will be in a big trouble. So those are the intraoperative pictures. This is angiography after insertion of arch branch device, and this is opening of the arch branch device itself. We are doing it with the lowering of cardiac output, and we can do it with rapid pacing, but we can also do it less invasively with inferior vena cava occlusion or Valsalva maneuver, which is very well described, and it works perfectly in my practice. Then you should cannulate the branches, and as you see on this picture, this is not so certain where the branches starts and what you need to cannulate. There are some markers, and you need to be very skilled or very experienced to cannulate it easily without any problems. So that the first thing that you should know is that if you want to treat arch pathologies with arch branch devices, you need a lot of experience with a lot of branched devices implanted. Then it becomes easier, and obviously you need very good operative facility. I mean, mobile arm, not mobile C-arm, but good C-arm to do that. And if you do it properly, this is final angio. This is the case with 2 branches and in AP position, when you can see very well the blood flowing into all supraaortic vessels, and postoperative CT scan. Talking about my own experience, I have operated exactly 107. The last was yesterday, patients with arch branch devices, and mostly it was those 3 branches. But I did it because I have done a lot of thoracoabdominal aneurysms in our department, and only 6% of them has been arch branches. As you can see, this percentage now is quite bigger, and it appears now more than 10% of our patients are the patients with pathologies of aortic arch. However, still the majority is thoracoabdominal aneurysm treatment. Obviously, the results are not super perfect. I can say that in all our 106 patients, the mortality was substantial, more than 11% due to dissection, due to stroke, myocardial infarction, or any other bleeding complications, and some other complications, minor complications. However, I'm proud of it that almost 87% of the patients has been discharged home in good condition out of those 106 patients. And those results correspond very well with the first descriptions which you can find in literature, where the mortality and complication rate was quite similar to ours. However, we are also joining our results with other results of bigger international groups, like in this article, and in this article of free arch branch device treatment, we have found only 5% of early death and 2.5% of major stroke complications. So talking about dissection, this is the very important indication for arch branch device. There are some patients that have type A dissection and they have urgently replaced only ascending aorta. And those patients are very good candidates for our treatment, because if you want to treat them by open surgery, you can see that there is a huge mortality of those reoperations in the chest, with reoperation mortality almost 15%, and serious complications 18% in this huge article combining almost 8,000 patients. That's why we have also published this article about arch branch after ascending replacement, and we have shown that in relatively small series, perioperative mortality was only 2.9%, and also permanent stroke was 2.9%. So this is our standard case of dissected aorta after ascending replacement, and those are some intraoperative pictures. This is free branch device while opening. This is opening of this free branch device. And then after completion, final angiography, where you can see all vessels and a little delayed blood flow into the left subclavian artery, because the branch to the left subclavian artery is retrograde in comparison with antegrade branches to brachiocephalic and left common carotid artery. And this is CT after operation. Obviously, there are some contraindications. We should have good ascending prosthesis. This is good ascending prosthesis. However, when it's too short or it's too kinked, it's very dangerous to do arch branch in such situations. Another very good indication for arch branch device is when we have truly type 1 or 2 thoracoabdominal aneurysm, especially with dissection like in this case, so that we can start with arch branch device and then continue with some thoracic and thoracoabdominal devices. And finally, there is a full metal jacket, and I have operated 56 or a little more patients with this method. 7 patients have been done first T branch and then arch branch, another 9 first arch branch followed by T branch, but I'm very proud of 40 patients operated simultaneously. This is a huge operation, but it's possible to be done, and I have more and more experience in those operations, and I don't see any reason to divide this operation into 2. About any novelties, we have recently started to use left common carotid artery reverse branch. It looks like this. It makes operation much easier than before. And here you can see this full metal jacket plus double reverse branch. And also we are using triple reverse branch, which can be done from one single incision in the groin. We can make operation of arch aneurysm with very good results. So as a summary, endovascular treatment of aortic arch can be done due to aneurysm or dissection, especially after ascending surgical replacement. And it could be done simultaneously with endovascular thoracoabdominal treatment. However, operations are difficult and should be done, in my opinion, only in centers experienced in complex aneurysm treatment and in good cooperation with cardiac surgeons due to possible complications. And on the end, I hope the future is here. Future is ascending aorta for endovascular treatment, and this is the first article published 4 years ago about first endobental procedure, and I hope that in some years we can talk about it more here. Thank you very much for your attention.
Thank you, Tomek, for a very, very interesting presentation. And I have for you a question, because I know that you don't like the PMSG. Yes, of course, sandwich, laser, homemade, and so on. But why? In short, you can say?
I find those produced superior than physician-made, because I don't believe that we are better than engineers. If engineers are developing something, they are sitting and thinking about it for months and years, and then they develop the perfect device. If we try to mimic the same, we are surgeons. We cannot do that. That's my opinion. The second thing is, obviously you can use PMEX when you have urgent situation. You need to do something urgently and you don't have anything available. But it's if I would be a patient, if I would have elective aneurysm or dissection to be treated, I would prefer to wait a little to produce a perfect device for myself, and then to be done with it. But sometimes it's good, and sometimes it works very well.
Yes, in urgent situation, yes, of course. We had once the patient, and during the test, he ruptured, and we used the laser technique in this case. Okay. Do you have a question from the audience?
Excellent presentation. Few very, very simple questions, because of course these devices are very complicated and devil is in details. I would like to ask you about, I know that you prefer the open access, even if you do the aortic arch and thoracoabdominal branches devices. Could you explain us why open, not percutaneous? Because 90% of early reoperation during the hospitalization I perform because of problem with the left brachial or axillary artery, and that is a problem, as of course nobody died because of this. But what do you think about percutaneous access for the, for example, brachial artery, and what kind of access do you use for aortic branch, especially of course for right side, because as you told us, the left subclavian is retrograde and you don't need any access.
To be honest, I'm not against percutaneous access, but maybe I don't know how to do it. I have seen it several times done by some other surgeons, and almost ever there were complications about that. And in my opinion, if you're doing an operation worth like 100,000 euro and the patient is prepared for so long time, so it's not very harmful for him or her to have just a small incision in the groin. Obviously, if you can do that percutaneously, if you are sure about that, you can do it. But most of the complications when the patient is heparinized is due to the bleeding. And I don't find major problems with axillary access. I'm doing it from both sides. Nowadays, depending on the facility where I do it, because it depends on the C-arm configuration. And I don't find a lot of problems there. However, also when you're doing especially axillary access percutaneously, you can face a lot of problems with brachial plexus. So I don't find it superficial.
Mm-hmm. And the last, as well, a very simple question: 1 stage or 2 stages in thoracoabdominal?
As you see, I have operated so many patients. If I would try to do them by 2 or 3 stages, I wouldn't have enough time to bicycle, because I like it very much. But being serious, I think there is no advantages of doing it in 2 or 3 stages, except the time when you have intraoperative problems. Then sometimes it's worth to stop the operation and to come back after a few days or a few weeks. This is the reasonable argument. All others, I don't believe.
Okay, thank you very much.
Thank you very much, Tomek. And next speaker, Dr. Janusz Saukas. He's absent. That's why now we have Dr. Christensen from Denmark with subject the non-syndromic ascending thoracic aorta in a population-based sitting a 5-year prospective cohort study from the Dan Cavas. Please.
Can you hear me? Very good. So, hello everyone. My name is Joachim Skopbo. I am from Denmark, Odense, and it is my pleasure today to present our study, the non-syndromic ascending thoracic aorta, in a population-based setting, a 5-year prospective cohort study from Duncavas. Nothing to disclose. We'll have a very short background. So the issue is that currently the surveillance programs recommended for dilated ascending thoracic aortas are vague. The more prominent guidelines recommend annual or biannual screening, and furthermore, generally prospective data regarding adverse aortic events still remains fairly limited. So we wanted to estimate the growth rates of the ascending aorta and also evaluate potential risk factors of adverse aortic events. We defined adverse aortic events as type A aortic dissection, thoracic aortic rupture, or thoracic aortic related death. So this is just a brief rundown of how the Duncavas study was conducted. This is a picture of Denmark, if you don't know. And we have all the data from both Duncavas 1 and 2. They were collected from 5 screening sites from 2014 until 2018. The age groups are from 60 to 74 years old, and we have quite a lot more men than we do women. So we have 14,000 men and just above 750 women. Each participant, of course, gave informed consent and participated with medical history and regular medical history. And then we did an ECG-gated CT scan and measured both of the thoracic and the abdominal aorta and did coronary calcification scores. We followed up with just some blood pressure measurements, both brachial and ankle, to evaluate peripheral arterial disease and hypertension. And then we finished off with some simple blood samples for diabetes. So when we had all the data from Duncavas, we supplemented it with the Danish National Health Registries. So in Denmark, we can have data on pretty much any individual. So we have data from the Central Personal Registration System. That's if they're alive, if they immigrated or migrated during the observation period, the Danish National Patient Registry, what diagnosis, what hospital visits, what surgeries has been done, and the Danish cost of death registry, which is kind of self-explanatory. This is our entire flowchart, and we will just break it down a bit so it's a bit more easy to comprehend. We start off with about 15,000 individuals, and we removed a few with key missing data and excluded individuals with prior adverse aortic event and bicuspid aortic valves. We also wanted to exclude any connective tissue diseases, but there were none. If you just focus on the right side of the PowerPoint here, we had around 2,000 individuals with consecutive CT scans. 5 of these individuals had a baseline ascending aorta of less than 25 millimeters and were therefore excluded. We did some preliminary analysis of growth rates and evaluated anyone with a growth rate with more than 2 millimeters per year or pre-standardized residuals. They were reviewed and possibly corrected if there was any wrongdoing. We had a follow-up of 4.1 years and about 5,000 CT scans in total. Every one of besides the excluded in the beginning, were followed afterwards from baseline until an event, surgery, death, or until the end of 2021. A complete follow-up time of 5 years, and in that time we had 23 events and 26 surgeries. So just for the growth rates here, we had an univariate growth rate of 0.08, which is on the low end of other reported growth rates. We did find that women had a significantly, but still slightly not very impressive growth rate either, of 0.13 millimeters. When we did an adjusted growth rate analysis, this is a violent plot, so we have the growth rate of the y-axis, and on the x-axis we have different categories based on the baseline ascending aorta diameter. We still don't really see any difference. The small p-value down there is between the largest group of above 50 millimeters, and it was insignificant. Now turning to our risk factors for adverse aortic events, we did find that age was actually a protective feature, which probably is due to a combination of some survivorship bias, and also the fact that we included only the age group from 60 to 74. Besides that, of course, the main dominant driver of risk seems to be the size of the ascending aorta, which is not surprising, and also that familial disposition to aneurysms also increased the risk. So in conclusion, the growth rate was very slow, of just below 0.1 millimeters per year, and questions the currently recommended annual biannual surveillance scans. Ascending aortic diameters of above 45 millimeters was a critical risk factor for adverse aortic events, as previously described. And we could wish for some more precise risk estimation, something in addition to diameter, which would make it much easier to stratify who needs surgery and what kind of surveillance. And I would just like to thank our collaborators and thank you all for listening.
Thank you very much for your wonderful overview. If I may start with the questions, you have found that 45 millimeters is the threshold for adverse events. Do you think we should reconsider our indication for surgery, or this 45 millimeters is just a threshold and then indication is still higher because the risk of surgery is higher?
Even with the recommendations are slowly falling a bit currently, but I would say that we had 23 events in total, and 95% of them were below 50 millimeters. So it seems at least that we should find something else than just size alone to spot who are really at risk here.
And you were probably excluded from your study connective tissue disorders, yes, like bicuspid valve exclusion and so on. And do you plan a study for connective tissue disorders also?
Not at the moment, not using this data set, because the issue was there was no one in the data set, so that's going to be limited.
Yeah, but I suppose you have a data, so that you can just find the data of those with connective.
Yes, you could do a completely different study without the Denkavis data, but then you would need some consecutive scans. But it would be possible, especially in Denmark, identifying individuals with connective tissue disease and with sequential scans for any other reason, and then get the data that way. That could be interesting. Yeah.
Okay. However, it's difficult to find them with normal aorta in the beginning.
Yeah.
Okay. Do you have any more questions or comments? If not, thank you very much.
Thank you.
And now, I would like to invite my co-chairman, Marek. The floor is yours, and the vascular treatment. You want here? endovascular treatment of ascending aorta pseudoaneurysm with aortocutaneous fistula by transapical approach.
Thank you very much for the opportunity to present my topic, endovascular treatment of an ascending aorta pseudoaneurysm with cutaneous fistula using a transapical approach, TAVR, transapical. Thank you very much for the invitation to Professor Arturas Mackiewicz. Endovascular treatment of ascending aortic pathology is nascent and still being studied for efficacy. Example, Amplacer ASD occlusion device for the closure of an ascending aortic pseudoaneurysm by Nicolas Condeleon. Percutaneous closure of a complex pseudoaneurysm originated from the aortic wall and connected to the left ventricular outflow tract was closed with a duct occluded by Lisa Karmans. Ascending aorta pseudoaneurysm after the Bental treated with endovascular coil embolization from the right coronary artery by Antonio Lisa. Transapical approach as an alternative route for TAVR in patients where femoral access is not possible. Aortic valve replaced through a small incision in the chest between the ribs. Transapical approaches offer better control and fewer device-related complications. Stages of the transapical approach: 5 centimeters thoracotomy incision and location the apex with echo. Rib retractor placement and left ventricular exposure. Epicardial ventricular pacemaker wise placed. Heart apex punctured between the plagid sutures with an 18-gauge needle. Soft guide wire advances across aortic valve into descending abdominal aorta. Replacement with Amplatz 260 centimeter long guide wire. Exchanged for the endoprosthesis delivery system. Endoprosthesis deployed. Double-checked graft position and endoleak presence using digital subtraction angiography with TEE, transesophageal echocardiogram, to exclude any injury. Chest closed and the pericardium and pleura drained. Our case report 80-year-old female patient presents weeping pre-sternal wound. History: breast cancer treated with surgery, chemo, and radiotherapy was responsible for a sternal osteoradionecrosis. CT scan showed 72 millimeters ascending aorta pseudoaneurysm with cutaneous fistula, severely atherosclerotic aorta. Our strategy: endovascular procedure due to condition of patient and porcelain aorta. Gore excluder, aortic extender to the short length of the ascending aorta. We can see this slide, pseudoaneurysm, and here ascending aorta and pseudoaneurysm. And anatomical consideration for TAVR. If ascending aorta is shorter than descending aorta or abdominal aorta, stent graft must be shorter too. ascending aorta limited proximally by coronary arteries or aortic sinus, and distally by brachiocephalic trunk. Length of the stent graft is limited by available proximal and distal landing zone. At least 20 millimeters are necessary for safe and durable fixation, especially in cases of short stent grafts. No custom-made short thoracic stent graft with long enough delivery system available. Our procedure was performed in a hybrid operating room. Rapid pacing, transapical and femoral throw and show approach were performed to improve deployment accuracy. Because of the ascending aorta strangulation, 2 stent grafts were needed to exclude the pseudoaneurysm. Ascending aorta pseudoaneurysm with cutaneous, we can see once again. And after first stent graft was deployed, a type 1 endoleak due to bird beak was observed and repaired. A shorter second stent graft cuff was then deployed between the left coronary artery and the ascending aorta angulation. The final angiography didn't show any endoleaks. There were no complications. After procedure, the wound stopped bleeding and pulsatility decreased. A patient was discharged after 13 days, 1 day in ICU. The immediate postoperative and 1 month CT scans confirmed exclusion of the pseudoaneurysm and permeability, the left coronary artery and innominate artery. We can see our results, our procedure, and post-CT scan didn't show endoleaks, and good permeability, the left coronary artery and innominate artery. Once again, we can see this coronary artery, and here we can see the stent graft inside. In conclusion, there's growing recognition of endovascular therapy as a player in the treatment of ascending aortic pathologies, particularly in patients that are unfit for open surgical repair. Endovascular treatment has successfully moved to the abdominal aorta, to the proximal descending aorta and beyond. It will be a matter of time until endovascular treatment will be routine practice for diseases of the ascending aorta too. Combining knowledge and technology will further pave the way. And open surgical treatment remains the most effective for ascending aortic pathologies. But endovascular treatment could be promising, but needs more study, acceptable for compassionate cases or atherosclerotic aorta. And thank you very much from Paris. And after Olympic Games, it was very interesting opening ceremony for me, but it was it was not okay with another people. And in 2 months, it will be 11 international meetings for progress in endovascular therapy in Krakow, which are organized by Professor Kuczmik, Professor Dryski, and Professor Kasprzak, and I organized night meeting for the Polish foreigner vascular specialists. Thank you very much for your attention.
Thank you very much for the presentation. For the successful case, I would traditionally ask the first question. If you would have a long enough device to do it from the groin, would you do that, or you would still go transapically due to the precise placement?
It is very, very good question, Tomek, because it is really, as I told you, it was the bigger problem with delivery system. But with, if you want to put stent graft by femoral artery, it's not long enough, and the prosthesis.
But if it would, I know it's more precise from transapical approach, but it's less harmful from groin approach.
No, I think that, of course, it will be more comfortable with femoral artery when we have the experience and so on, but we don't have another solution in this case. Maybe it will be example for the treatment of ascending aorta, as you know. We prepare, people prepare the endobental, as you remember, last one in Krakow, it was the session about this endobental with a surgeon from Brazil who has experience with endobental.
Yes, but there are some other problems there. Anyway, there was a problem of very short distance between the origin of aneurysm and the carotid arteries, which was paramount importance not to cover them,
Yes.
and you did it perfectly.
Yes, in addition, as you remember, distance between the brachiocephalic trunk and coronary artery, it was only 56 millimeters, but we used the gore, the extension gore, not the prosthesis, extension gore with 40 millimeters in length.
Okay, Linus.
Thank you for a nice presentation and successful case. My question will be, if you have artificial aortic valve, could you perform this procedure from the apex?
For me, it will be contraindication with this. But in this case, we don't have.
If I can add, it depends on the diameter of the valve and the kind of the valve. If it's a bicuspid valve, probably it wouldn't go through. But when we're doing arch branches, we have done several cases, and recently we published an article about passing through the artificial valve, and it's still possible to do it with the wire, to do it with the tip of the stent graft. So probably with quite narrow device like Gore device, it would go through. You should measure that. And in many kinds of artificial valves, it's still possible. On the beginning, we thought it's absolutely impossible, and we thought it's a contraindication for arch endografting, and we tried some other maneuvers. But nowadays, we know it's possible, and it doesn't harm the valve at all. Piotr.
Thank you very much for a very interesting presentation. And now I know that you show us how everything is changing, because now we always think about the endovascular procedures. So I think that 20 years ago, surgeons will measure the device, measure the length from this pseudoaneurysm, and decide to use, for example, retroperitoneal approach from the iliac artery, even for small incision of the abdominal aorta. There is no too small device, but thinking about all the procedures is different than 20 years ago. So now it's my idea that maybe it's a good idea to do the small incision of abdominal and use aorta as an approach for that procedure. Yeah,
Yes,
everything
yes,
is changing.
yes,
Thank
of
you.
course, Piotr. Time flies, and we go to the really the future, and we will see.
Okay, thank you very much. And now it's
Thank
my
you.
pleasure to invite my friend Linas Velicka with the presentation, the vascular treatment possibilities for patients with congenital aortic syndromes.
Dear colleagues, dear Thomas and Artura, thank you for this outstanding meeting. I want to share our experience with endovascular treatment possibilities for genetic congenital aortic syndromes, together with Victoria Kvadrat and Eglė Reminienė. It's our beautiful city, Kaunas. No disclosures. Epidemiology. So epidemiology, or in general population from 7 of thoracic aortic aneurysms and 4.6 of dissections. We have about 20% of them familiar and 28% of heritable dissections, and this caused significant cardiovascular mortality. Patients with aortic pathologies significantly younger comparing with sporadic groups, and the life expectancy of Marfan's is about 70 years old, and in other diseases it's much shorter. It's like Ehlers-Danlos syndrome will be 88, and Loeys-Dietz syndrome 37 years old. Aortic disease is more aggressive in patients with Loeys-Dietz syndrome and dissection, and this happens in a smaller sizes. If we look to syndromic and non-syndromic, so syndromic is having the small part of all this pathology, and every syndrome has the particularities which are significant for diagnostic and treatment. One of our patients with Loeys-Dietz syndrome, 37 years old, his aneurysm grew up very fastly, and we under-evaluated this, and the next day after a visit he died, just because it was 7 millimeters of in size, and this increased very rapidly. So this is really tough patients and tough cases. As we know, for our genetic and hereditary, the surgery is first. And in comparison with sporadic aneurysms, we can have the room for endovascular treatment, and this is confirmed by recommendations. And for heritable is the open solution, the one. And of course, for heritable, we should act much earlier. And as we have heard in previous presentation from Denmark, that 45 is this threshold for a bigger amount of aortic incidences. So with heritable diseases, we need to act much earlier. And so of course, and the growth rate is the smaller numbers, like 1.3 centimeters per year. It should be patient treated before the waiting. So if we do endovascular for heritable disease, did we stay on safe side, and is it good for our patients? This is raises the controversies. Endovascular repair in patients with Marfan syndrome have reintervention rates ranging from 11 to 55%, chronic aortic dissection from 41 to 100, rates of endoleak up to 45% in hospital mortality rate with redo aortic surgery and complex aortic pathology is 44.1 to 15.4%. Up to a quarter of patients have new dissections and stent placements. By the other hand, the literature we have, and this is growing, experience that still we can safely do these procedures with, and the first advantage is much safer, and it's low mortality rate, and we can do urgent and elective endovascular repairs in patients with in acute and chronic situations, and endovascular interventions had a high rate of early technical success, low perioperative mortality, and midterm survival rate compared to open surgery. And we have the register, stat register of genetic aortic syndromes, and we include 86 individuals to this, and from this we find 24 cases of heritable with aortic phenotype, and looking to sex, it compares equally, and in sporadic group, in control group is much higher rate of males. Of course, these patients, they are younger, and genetic is with cardiovascular phenotypes is half of the patients, and of course, the most of them, they are Marfans. A quarter of these patients were treated purely endovascularly or with hybrid staged procedures, and about 40% they are under surveillance. And our cases, young lady, 54 years old, at 33 she was diagnosed aortic aneurysm, and she get aortic prosthetic graft, and at 50 ascending aorta graft, and at 50 she get aortic prosthetic graft. Then she developed type 2 dissection, retrograde, and first step what we do, we put the stent to fix the arch, not to progress to the arch, and in later this symptoms start to worsening, and we decided, and with the help of Tomak, we did aortic stenting with T-branch, and after this patient, she writes the book for the children's, and she is pretty doing well. 42 years old, Marfan syndrome. She had a bendal procedure and repeated procedures several times, and she come to us with dissection type B from subclavian region to bifurcation, and at that time the branch devices were not possible in our setting, so we decided to do hybrid procedure, first placing stent graft to the thoracic aorta, and a few weeks later we replace abdominal aorta under God shunt. And after procedure, she was okay. She have had the healing problems of the wound, but with back therapy it was fixed. Then in a follow-up, 5 years later, we find that there is aneurysm formating between the connection of two stent grafts, and then we place additional stent graft here. And young lady with 24 years old with Loeys-Dietz syndrome, she had surgery for ascending aorta and repeated surgeries and thoracotomies and sternotomies. So when she develops a pseudoaneurysm in orifice of subclavian artery, cardiac surgeons were not keen to do open surgery. Then we perform hybrid procedure with arch debranching, subclavian artery to left carotid, and vertebral artery transposition to left carotid. And then we placed the stent. After this, patient did pretty well, and we followed this patient every half year by CT, and we find that the internal mammarian artery becomes aneurysmatic, and this was fixed with embolization to thoracic internal artery. So let me to conclude that endovascular treatment is valuable tool for stage O and hybrid treatment of congenital aortic pathology. Strict follow-up is mandatory for congenital aortic pathology, and genetic awareness is mandatory for TAA and TAD patients. Thank you.
Thank you very much for this presentation. Does anybody have any questions? If not, I can just a quick comment. There's a perfect solution. The case that you shown that cardiac surgeons replace a part of the aorta, and then we have a good sealing zone,
Yeah.
especially proximal sealing zone in those connective tissue disorders. Otherwise, I have a good experience, but it's still out of the recommendations to do it without any artificial sealing zone. Thank you very much.
Now Dr. Novak from Budapest will present subject trial and AAA treatment. Please.
Hello, everybody. First of all, I would like to thank the organizers, Arturas and Thomas, for inviting me for this exceptional congress. So my topic will be trio in AAA treatment. This is a controversial topic, so these are my disclosures. Controversial topic, as I will talk about the urgent situations for juxtarenal aortic repair or complex AAAs. Maybe it's easier if I hold my hand. Thanks. So an urgent, emergent options for the treatment of AAA aneurysm, complex AAA aneurysms. So there is an open surgical solution, as we know. Also, there you can do a hybrid repair with an iliovisceral debranching, and several endovascular options are also available for you to follow. You can do the off-the-shelf BVAR. We heard it's quite convincing, actually. Some of the centers prefer to use CMDs of dummy patients or devices ordered for other patients in an elective or in an urgent setting. There are some centers, for example in France, following the in situ fenestration for such repairs, also for parallel grafts in Germany. And there are several centers who treat these patients with physician-modified devices, such as we do. So as you might know, these devices are based on either tubular or a bifurcation designed devices with modifications, fenestration, scalloped diameter reduction, and so on. So why is the Trio an ideal platform for physician-modified endografts? One thing is that it has a long body, a long main body. It has a 90 millimeter from the proximal edge to the flow divider, which makes it very comfortable to find a place for all 4 branches if you're treating with a four vessel design. Also, it's important to know that it has very few struts. I believe it's very important not to go too much with the modifications. I tend not to remove or modify the struts of the device, only to cut holes on the fabric. And also, as it's a bifurcation already, you really don't really need to extend it with bifurcations as if you were using a tubular TEVAR implant. And as you will use a bifurcation, not a TEVAR, you can use a smaller device. Usually it's like this, 18 or 19 French, contrary to TEVAR, which are usually larger than this. The distal fixation within the sheath during the deployment is really important. It's a minor addition. For standard cases, you don't feel that it's important, but as if you try to deploy some of the other stents, it's quite easy to slip out of the sheath if you are already almost completely deployed your device. And it has a durable proximal clasp, which is important during the manipulation and the modifications of that device. If you have opened inadvertently a proximal clasp during a proximal or a physician modification, you know what I'm talking about. I believe the only con against this platform is that it's not the easiest one to reload, but that is associated to the reused profile. So we established a pretty streamlined workflow. So I consider myself an outlaw, such as this gentleman here from the 19th century. We've just accepted this manuscript in the Journal of Vascular Surgery, Cases, Innovation, Techniques, which involves all the steps we follow during these procedures. The first one is this punch card technique for positioning. This is, I think, really a simple tool to achieve a position on any kind of implant where all 4 fenestrations sits at a strutless area of the device. That means that you don't have to hassle with the modification of the struts itself. The next one is the reinforcement. So we need something to reinforce the fenestrations. I don't believe in reinforcement with the snare loop or either with the guide wire tip, as these are not really reinforcement, but rather as a circular marker without any reinforcement. So once you dilate these reinforcement rings, they will dilate with the flaring balloon. This is proved in our in vitro study, which I show you here. So if you use a snare loop, a single loop of a snare loop tip, it will dilate at a very low pressure, notwithstanding the flaring maneuver, such as if you are using the Hungaro ring or reinforcement ring. It can withstand the high pressure dilatation without distortion of the reinforcement ring. And there's a growing concern regarding the needle holes on fabric. Although this is also a controversial topic, some of us believe it could be a problem on very long term. Some of us don't think that that is a problem. However, you can create a non-perforating diameter reduction with the proper technique below the struts but outside of the fabric. And you can reload these devices with several options. This is my favorite one. I've learned it from the social media, actually. I've seen it there first, so it's not my idea. But you can use that TEVAR crimper for balloon expandable aortic valves to reload these devices quite easily as opposed to the other techniques. And you can also not neglect the financial aspects of that repair. That is especially important in Hungary, where we struggle with the reimbursement of custom-made devices. So this is 1/4 of a price compared to a custom-made device. So what about our results? So we completed the first case in last May, and based on the initial success, it helped me to convince our fellow vascular surgeons who were originally quite skeptic about this technique. But now we are in a situation where we offer this physician-modified device FEOR to our patients, also elective patients with juxtarenal and perirenal AAAs. This decision is always an aortic team decision, the proposal, which the patient usually accepts after an informed consent, and we do this under an ongoing observational trial. So we have completed 25 cases since last May. As you see here, it's an average patient population for aortic disease with an average aneurysm diameter of 70 millimeters and a pretty higher than normal risk for repair. These are the operative data. We completed 3 cases with a single fenestrations. These were accessory renal arteries, but besides those, I always try to involve all visceral arteries and aim for a supraceliac landing zone and fixation. Preparation time is around 1 hour, and we do this procedure with a considerable amount of contrast agent and fluoro time. You see the hospital length of stay is around 4 days. What I emphasize is that the 90% of the cases we didn't need an ICU after the procedure. Per vessel technical success rate was exceptional. We lost a single celiac trunk and 2 small renal arteries, which I thought we'll be able to cannulate, but those were too small, so I failed. What we didn't expect or experience any major adverse event, either stroke, myocardial infarction, bowel ischemia, or newly onset dialysis. But I have to admit that the average follow-up time is rather short, so this is a newer concept that we are following, so it's less than half a year on average. But we were able to achieve a clinical success in 24 out of the 25 cases, and we only lost a single patient due to an intracerebral hemorrhage not related to the aorta. So this is one of our cases. As you see here, it's a small proximal neck infrarenal or juxtarenal aneurysm, not exceptionally big, but it's an asymptomatic patient, and we offer this treatment technique. This is the intraoperative view. So the reloaded system looks quite similar to the custom-made trio, which you can order now. The right side of the image, you might see that there is the partially deployed system with the left renal still need to be stented. We also confirm our repair with an on-table cone beam CT unenhanced, just to look for proper flaring and the structural integrity of the metal parts. And this is the 30-day follow-up CT of this very patient with patent 4-branch repair, and there's no endo leak in the aneurysm sac. So this is how we feel actually, quite enthusiastic about this device. Just after the ignition on a Starship, we established this pretty streamlined workflow, which is quite fast and standardized. It is surprisingly effective, and it's surprisingly safe, and cost effectivity rocks. So thank you for your attention.
Thank you very much for a very interesting presentation. But I have a question. Why you use the trio valves? Because in my department, I had a friend or colleague who made the homemade with cook. He has about 40 cases, and another in Paris has almost 100 cases, and he used the Medtronic Endurant. For you, what is the why you use the trio valves?
Thank you for that's an insightful question actually. So I prefer the trio as it contains much less struts compared to either the Cook bifurcation or the Medtronic. So Medtronic is the most densely packed with struts, so it's quite hard to find a position when you're treating with a 4-vessel physician-modified endograft. So if you need 4 holes in a very specific position and you need to maintain their relative position, it's quite hard to achieve that with a densely packed skeleton. So I prefer the trio as it contains only 4 rows of stents during that 90 millimeters. And also if you take a look at the endurant, it is only 54 millimeters from proximal edge to the flow divider, which is usually a little bit less than needed for a 4-vessel repair. So if you are dealing with 2-vessel or 3-vessel, then it's fine. But if you are treating 4-vessel, you most likely will need a longer main body, such as the Cook, or I think it's better a little bit for this, from this point of view, the trio, because it contains less metal that is in place.
Next question from Linus.
Thank you for a nice presentation. My question was concerning money. You show that this device is 10,000 euros. So it's only for trio graft, or is for branches as well?
It's for just for the aortic components. So you will use your branched grafts regardless. You will use a custom-made device or a physician-modified device. This is just for Hungary. It depends on which country you are, how expensive these devices are. Unlucky enough, in Hungary, trio is already one of the most expensive devices. But still, if you take that as a custom-made fenestrated solution, it's much more cheap than company manufactured devices. Okay. But that's for aortic components only.
Okay, thank you.
I have one more question. If you're doing that perfectly, and the results are excellent, but in comparison with company-produced fenestrated device, you don't have any diameter reducing ties. Do you also think about incorporating that? I know it's possible to do that manually also. It takes some time, it takes some effort, but do you find it worth?
Yeah, that's also a good question. So we implement circle diameter reduction on our devices, although it's a little bit controversial. So if I think it's Benjamin Starnes who thinks that there is no need to use diameter reduction over a trio device with this twist maneuver that is most likely collapsible after deployment. I've not yet tried that technique, so I cannot state that. Maybe I lack the courage currently to do that. But with this circumferential diameter reduction, which are rupture after deployment with a compliant balloon, non-compliant balloon, not compliant balloon, it's quite easy to do that and without a hassle. Yeah, so it's not trigger-based, not trigger wire-based, but it's a circumferential.
It's easy for you or for a few persons, but for most people it would be much more easier to have those ties. Anyway, thank you very much and congratulations.
Thank you.
And the last presentation from this session will be given by Dr. Gircius. And the title is A Complex Case of an Internal Iliac Aneurysm Endovascular Treatment.
Yes. Okay, so, the patient, 80-year-old male, no specific symptoms, but a size largening iliac aneurysm in time, some mild cardiological anamnesis, and I would like you to show images, but they would take ages, so I would just go straight to the snippets. So the common iliac on the right, quite large, the 5 centimeters, then going down the hypogastric as well, aneurysmatic, and the size of it is also 5 centimeters with the complete occlusion by thrombus on the ostium and the backdoor filling from the distal portion of internal iliac branches. So if you're into classification, probably the closest variation would be type 3. And I'm not going to spend a lot of time about recommendations of treatment, when is the size, because it's going to be covered tomorrow heavily by other speakers. So we made a short plan of endovascular treatment. doing it in 2 stages. We really wanted to close the back door because it would probably leave the back door flow for the internal iliac and then probably future problems. So it's like a predetermined type 2 endoleak already. So we would like to embolize that in the first stage and then do the endovascular treatment plan, do the graft implantation. We opted to do it as minimally as possible. I will show you a little bit further what we were thinking about. So here you can see a very nice collateral arising from the supreme sacral artery with the feeding of small branches and parallel branches into the internal iliac distally. So we wanted to stage it as a second stage procedure in a fashion to put one graft, one limb, but we ended up in with a problem that proximal part is around 18 millimeters in diameter, and at that point where we were planning this procedure electively, we didn't have anything to choose from. So we decided to take one limb in a fashion to to implant it reversely. So we needed to deploy it on table and then reverse it and pack it inside. And now I see that there's actually a device to help to do that. You will see how we struggled. So stage 1, embolization done in the outpatient ward clinic. Patient came in the morning. And we tried to do it, so we catheterized on the left, found the feeding artery, tried to advance with a wire and give it some time. You might see something, all right? No, not yet. Hopefully we will succeed. Yes. Okay, look at this. And all right, we're in. Yes, we're in. Now control. How are we doing? Well, damn. Now we have a bleeding, so everything is off the rails. What do we have to do now? We have to stop the bleeding. Luckily, we're inside with the catheter, so we apply some glue. You can see a tiny bubble here, which is extravasation of glue, which we want to see. Now at this point, you know, this is our vessel that we have to get in. So at the same time, you're in trouble, the patient is in trouble. It's bleeding, active bleeding, quite large vessel. And this is your one door where you have to go through the back door. You have to find more collaterals to get into internal iliac. Luckily, we had plenty, so luckily we have stopped the bleeding, and we still have some collaterals to go further into the iliac, internal iliac. Okay, so after half an hour, we managed to put our microcatheter into a thrombosed internal iliac aneurysm through back door, and we applied glue. It's coming slowly. Probably would want a little bit more, but it's okay. I'm gonna run this one as a second. So I wanted to do, I knew this is gonna be one-time opportunity, so I wanted to close it thoroughly, so it wouldn't be, so I don't need to come back again. All right, so the final run of the embolization, I think the job's done. We even managed to save the superior sciatic artery. Okay, so what we did, we deployed as a graft implantation, we opted for a Cook graft, a limb. So we took the older system, which is a little bit larger, so it would be easier to reload it again. So we used an old tool, which is a suture. We rolled it, we applied with the sheath, we unrolled it. And, you know, probably we would have, now, when you go retrospectively, it would have taken us quicker to do the simple EVAR than this. So we spent around an hour only playing this on a table. I don't think I would want to do it this one more time, but then again, if there's a dedicated device for that, maybe. I didn't know. Okay. So we placed it. Of course, I wanted to place it perfectly. Now it kind of jails the left common iliac. What to do? We measured the pressures on the left side. We did some ultrasound in the operating theater, so there was no changes in the flow, so we left it. Unfortunately, we failed to close the right groin. Now we have a bleeding that we failed to close, even placing a stent graft from below. So we asked the fellow surgeons to help us. So it had to be done perfectly endovascular, right? But we failed. So anyway, after 2 months, unfortunately, this CT will also take, well, maybe we can, if we have a minute or two. I tried. It doesn't, well, maybe it will let me, no. Now it starts again. Okay, I'm gonna skip it, just straight to the snippets. It's okay, it's a little bit jailing the left common iliac, but then again, patient has no symptoms, the pressures are equal. I don't know, we don't treat pictures, right? We treat the patient. If the patient is doing okay, maybe let's leave it for if the patient develops symptoms. So no feeling of both of the aneurysms, and I'm quite happy with my glue. And after the bleeding embolization in the first session, patient had no symptoms, so we discharged him the same day. And 2 days after or that was 3 days after the surgery of the graft implantation, also the patient was discharged. So when he came back after 2 months and we did this control CT, he told that he had some minor pain below the knee. We did ultrasound, we found that there was deep venous thrombosis below the knee, so we prescribed some anticoagulation. Otherwise, patient is doing nice. Questions?
Thank you very much for this presentation. First question.
Congrats on the successful management of the case. Yeah, just one comment regarding, so it would be a reverse mounting, right?
Yeah.
I think that if you are aiming for a reverse mounting, then the best tool is the Gore excluder limb, because you don't really need to deploy the device. You just need to cut off the tip, put it upside down, and you can use the original trigger thread to open your device in a upside down fashion. That's the most simple way to do that.
That was our first one. I hope we don't need to repeat that again. That was very hard.
So if I may comment, two things. First of all, when we are trying to embolize hypogastric from the backside, we usually puncture the gluteal artery directly, which is the easiest way, and you have direct way to the hypogastric, and it's probably a little easier or less complicated, but that's your choice. And about reversal of this leg, I've done it several times. Nowadays it's like 10 minutes, but in the beginning I know it's a nightmare. But you can choose some other devices that can fit. For example, you have a big limbs of Jotek device, which are even better because they have some valleys just for such a cases like that. Not only one company can accommodate it.
Now we do have Jotek actually now, and I think Anaconda as well has a big limb or if I'm mistaken, I don't know, need to. But at that point when we were doing this, we didn't have the chance to have that.
Yeah. So since there are no other questions, we are a little ahead of time, but thank you very much for this excellent session, for the discussions, and for all questions. And we have a break now.
another computer. Good afternoon, everybody. The last session from the first day of the Vilnius Vascular Symposium. My name is Priit Põder. I'm coming from Estonia, from Tallinn, and Patricia Ivanova from Riga. So we are moderating the last session, and the first presentation will be Professor Krievinch from Riga. Please.
Good afternoon, Chairmans, and thank you, Thomas and Arturas, for inviting to this meeting. Actually, I like last sessions, you know, and especially after the lunch break. So, but I'm happy to see at least somebody here. There's some speakers and some extra, but anyway, great to see you. And my topic today will be not about the surgeries or endovascular treatments themselves, but I will speak more about survival of our patients. And when we're going to international meetings, very often we are having long discussions and sharing across everywhere about mortality, 0.5, 0.1% due to drug-eluting stents or balloons, etc. So today I would like to speak about more severe problem we're having with our patients and maybe how we can improve survival of our patients. I have no disclosures for this presentation. So basically we know the primary cause of death for our patients with chronic limb-threatening ischemia is coronary artery disease. And when we look to the data, then 1 year mortality is 10 to 20% and 5-year mortality exceeds 50%. And it's therefore, when we look to our guidelines, European or American guideline recommended strategy for reducing risk of cardiac death and MIs following lower extremity revascularization is just evidence-based medical therapy and risk factor control. So this means usually in our clinics there is no additional checkup done, just if there's no symptoms, ECG, and proceed to the surgery. So, and what about medications? In last 40 years, there have been huge improvement of medications, and despite of all this medical therapy, still when we look to the very large data, 168,000 patients, which was SafePath study, 5-year mortality 55%. So it's really big numbers. So this means the new strategies are needed to reduce the cardiac risk and improve survival for our CLTI patients. So recently, the new non-invasive test which provides both, not only anatomical, but functional assessment of coronary artery disease been developed, and this is FFR-CT, which is basically coronary CT-derived fractional flow reserve, which is done with special computerized system. So, and this FFR-CT can identify CLTI patients who have high-risk ischemia producing coronary lesions using this new non-invasive technique. And it's never been done before, and actually our study was just to prove it, but it could change mortality of the patients. So, and the study objective was to determine whether, in addition to best medical therapy, a strategy of selective coronary revascularization can reduce adverse coronary events and improve long-term survival of CLTA patients compared just to the best medical therapy. We published this in a couple of years ago, the study. So there are more departments being involved, not only vascular surgeons. It was cardio anesthesia, radiology, cardiology, and cardiac surgeons. So basically what we had, it was just case control study. We took patients with CLTI patients, and in one group, patients underwent just regular best medical therapy treatment and a regular evaluation, which was ACG if there's no any cardiac symptoms. And other group patient actually, and on top of this regular ACG, underwent coronary CT and FFR CT evaluations. So I want to point out one more time, these were asymptomatic patients, coronary asymptomatic patients. So study endpoints at 3 years were MIs, cardiovascular deaths, all-cause deaths. And when we look to the groups, it was 103 and 120 patients in each group. Groups were very similar regarding the main diseases for this cohort. So, and what the results showed? The results showed that this in FFR CT group, where we did pre-op coronary CT and FFR analyses, asymptomatic coronary ischemia was in mostly 70% of the patient. Severe ischemia was 58%. And of course, we're expecting some disease, but not so high numbers. And what was very interesting, left main was 8% of the patients. And here you see on the left side, in the red, you see FFR CT shows you where is a severe drop of the pressure and significant stenosis. You can see the disease, which was 69% of the patients and 31% of the patients. You see on the right side, there is no red sign, means there is no ischemia. Of course, in control group, status of coronary ischemia was unknown. In FFR CT group, post-op coronary revascularization was done in 46% of the patients. 42 patients underwent PCI and 5 patients underwent CABG. And you see in the left side, there's a case example of one 67-year-old diabetic patient with ischemic ulcer, and 1 month post-FEMT bypass patient underwent PCI. And you see the difference, why we need this FFR CT exam, why CT is not enough. You see from CT scan, you cannot tell anything because of calcification. And these CLTI patients are very calcified. They measure the Agatston score, which is in thousands, which basically you cannot say where is the stenosis, and you cannot say what is the functionality or functional drop of the pressure. So at the same time, you see the fast right side, red color shows where is the disease and where it should be treated. So at 3 years outcomes, results showed 86% reduction in risk of MIs and 86% reduction of cardiovascular death in FFR CT group. Huge reduction. So when we look to all-cause deaths, then there was 68% reduction in the risk of death. And then we compared our data with our conservative group. We had 28% mortality in control group. Our data were even better than when compared in literature. Swedish registry is 41%, meta-analysis or SwedePAC randomized trial 33%. So in conclusion, from our study, we found that pre-op evaluation of CLTI patients with no known coronary artery disease using CTA and fractional flow reserve evaluation revealed that 2 out of 3 patients had silent coronary ischemia, placing them at high risk for future cardiac events. And selective coronary revascularization following lower extremity revascularization resulted in fewer MIs, fewer cardiovascular deaths, and improved 3-year survival compared to the CLTI patients just receiving standard best medical therapy. And of course, this is a single-center study. It's not a randomized study, and it can give us some sort of idea, but we need randomized studies to prove it. And our studies already got some attention, and 2022 European Cardiac Society already included this in some guidelines. So, but to make more evidence, we started a SCORPA trial, which is a randomized study. And this is the first multi-center randomized trial in this indication. We started February this year after Latvian government gave us some restricted grant for that, and Heartflow gave us research discount for exams. And yeah, and thank you, Professor Björk, for attention of this study and inviting us to write a research letter for European Journal of Vascular Surgery, which later get attention to Vascular News this month as well. So, and basically this SCORPA study is very similar what was done before. The main difference is we're doing this coronary CT scan and FFR exam not before revascularization of lower extremity, but after. So, and basically one group of the patients undergoing just best medical therapy follow-up, and other group patients receiving best medical therapy, and on top of it, coronary evaluation and coronary treatment if indicated within 3 months after lower extremity revascularization. So our endpoints are at 2 years, and there will be extended group with evaluation up to 5 years. So currently we are included in the study 140 patients. These are 2 sites in Latvia, and our Stradins University Hospital in Riga, Alströms University Hospital, and there's multiple countries and sites already looking to participate in doing some paperwork, and we looking for more sites to be on board for this very important academic study. And at the end, just a couple examples already for this new randomized study I would like to share with you. This is a woman claudicant after FEMPAP bypass, 77-year-old, and you see on the left side severe calcification in coronary arteries, and an FFR CT reveals severe stenosis. And this patient underwent, quite complicated by the way, PCA, and this is another patient with 3-vessel disease, as you see from the FFR CT result, and patient underwent a coronary angio and later on been forwarded to cardiac surgeons for 3-vessel CABG. So currently 61 FFR CT was done, and 23 patients already underwent PCI, 2 patients underwent CABG procedure. So currently this is our randomized trial data for these 140 patients, showing pretty similar results compared with our previous study. But of course our target is at least 500, but we are targeting up to 600 patients to make the study more scientifically powerful. Thank you very much for the privilege to present this data here in this meeting.
Thank you, Professor. Any questions from audience? Please.
Oh, thanks a lot. That's a great initiative. I have tried to convince our cardiologists for something similar. Just one question. At least in Denmark, there's a huge mortality risk in revascularization of critical limb ischemia patient. Have you considered whether this timing is the best time, or should you do it prior to revascularization of the limbs?
Mm-hmm. This is actually a very good question. I think we could discuss this regarding the claudicants, but regarding COTI patients, if you're having a patient with an ulcer and night pain, of course you have to treat first what patient comes with. And frankly speaking, for our previous study, when we had this group of 200 patients, more than 200 patients, we didn't lose any patients or mice on time of revascularization, because most of them undergoing spinal anesthesia, and well, frankly speaking, our anesthesia is pretty good. So, but this is a very good question, and for example, in South Korea, which will participate in our study as well, they said, hey, we'll have not so many patients because it's already standard of care. it's already standard of care to do coronary deep exam before any vascular revascularization. That's, I mean, you are very right regarding that. And yeah, Denmark is very welcome to participate as well in the study for sure.
One more question?
This was the same question.
No, but even from this study, we received like from FFR, CT, from Texas, from Hasbro, at least 3 times emergency emails saying, hey, 3-vessel disease, this patient is really urgent. So, and we called this patient immediately to the hospital. Yeah. Thanks.
So, thank you very much.
I would like to invite the next speaker, Dr. Lindholt, about the cardiovascular risk in EPED patients. Please, stage is yours.
Chairman, ladies and gentlemen, firstly, I would like to thank the organizers for this chance to share our observations of the epidemiology of PAD based upon population-based screening. I'll mainly use the VIVANT and CAVAS trials, which randomized close to 70,000 men in the 60s and 70s. And in order to address the sex as a risk factor, use data from a population-based screening program in the municipality of Viborg, also called VISP. All 3 studies or cohorts use the same standardized method for ABI measurement. One, if not the only, validated Doppler-based measurement using both crural arteries. Ideally, such measurements should be done after resting in several minutes, but as in the out clinics, there's not time for that in screening. So we very soon experienced in VIVA that if we didn't measure the brachial and ankle pressures synchronously, it would cause a lot of false findings. If you measure the brachial pressure first, it would cause a lot of false positives and vice versa. Our definition of PAD was an ABI below 0.9 or incompressible arteries above 1.4. Regarding sex as a risk factor, 6.6% of all 67-year-old men versus 4.5% women had PAD. So that's about a 50% increased risk of male sex. When adjusting for multiple risk factors, it decreases to 30%, especially because smoking and diabetes is still more frequent in men, but also hypertension and hyperlipidemia are more frequent in men. And only 10 to 15% of the PAD positives were actually known prior to screening. If we look at VIVANT and CAVAS-1 trials, which examined the same age group of men, the prevalence is completely unchanged between the 2 periods. As survival generally increases, I would actually have expected it to decrease. But it is stable around 10 to 11%. But 2/3 are asymptomatic, so the prevalence of intermittent claudication is stable around 3.5 to 4%. It came as a surprise to me to experience that 1 out of 4 of these 65 to 74-year-old men actually have pain, walking, distance limiting pain. but only 3.5% actually had intermittent claudication, and that's only 15% of the population with walking limiting pain. So that's probably why intermittent claudication is so underdiagnosed. Regarding independent risk factors, they're here. If the study period is included in the multivariate regression analysis, the risk of PAD has actually decreased from the VIVA trial to the Dencavas trial by close to 20% when accounting for known risk factors, as an indication that morbidity is increasing in our society. A history of acute myocardial infarction or stroke was associated with 4 to 5 times increased risk of also having PAD. And the smoking history increased the risk 3 times, but diabetes actually only increased the risk by 50%. And that also surprised me. Merging such 2 large data sets materials allows us to take a seldom look into the risk of incompressible arteries, here defined as an ABI index above 1.3, identifying 526 cases corresponding to 1.5% of the population. A bit surprising, not being current smoker was the strongest independent risk factor. An active smoker actually had 80% reduced risk of incompressible crural arteries. This is probably most likely a kind of a biased by indication. And that was followed by the second largest risk, that was use of systemic glucocorticoids. But they only account about 3% of all cases with these incompressible arteries. While the risk for a diabetic patient is also around that area, about 4%, but they account for a quarter of all the cases. But that also means that 3/4 of patients with incompressible crural vessels do not have diabetes. Regarding need for revascularization after 5 years, 8.3% of claudicants were revascularized. That's approximately half of what we experience in our outpatients, while 5% of the asymptomatic PAD cases had revascularization. So ABI measurement screening is actually a good discriminator of need for later revascularization. There's only 3 out of 1,000 no PAD cases had a need for revascularization later. If we split it up due to claudication or critical lower limb ischemia, the risk of need or progression to critical ischemia was only 2%, suggesting it is still a quite benign disease for the legs. It was insignificantly a bit higher among those without symptoms at screening, indicating that many of them are probably just inactive, so they are not having any symptoms. When it comes to the risk of amputation, a bit more than 3% of all PAD diagnosed cases were amputated during 5 years, a bit higher regarding claudicants compared to asymptomatic cases. 3 out of 1,000 normal persons were amputated also within the next 5 years. When it comes to the 5-year mortality risk, about 18% of all PAD diagnosed died during the period. a bit higher regarding claudicants compared to asymptomatic cases, and about 2.5 times higher than the background population. And this is in spite of being detected and put into preventive medication. And it doesn't really see that modern cardiovascular prevention helps these people a lot. So in conclusion, ladies and gentlemen, 1 out of 4 of all men aged 65 to 74 have pain-limited walking. 11% of the men have PAD, but only 4% have intermittent claudication. Ranked by decreasing risk, former acute myocardial infarction or stroke, smoking, hyperlipidemia, diabetes, hypertension, and sex in the end are still independent risk factors for PAD. Being non-smoker or using systemic glucocorticoids are stronger risk factors for incompressible crural vessels than diabetes. But 1 out of 4 with incompressible arteries have diabetes, but on the other hand, 3 out of 4 do not have it. Within 5 years, 6% with PAD will need revascularization, and 2 due to critical ischemia, and it's equal whether you have symptoms or not. Close to 3% will undergo major amputation, also almost equal in the 2 groups, symptomatic or asymptomatic. And 18% will die, also equal in the 2 groups. And that's unchanged, about 2.5 times higher than the background population. Thank you very much.
Thank you. Any questions from audience? If there is no any questions, then I would like to invite the next speaker, Dr. Helena. Please, stage is yours.
So this is next, right? Just a green one. Slideshow here. Thank you very much. Thank you very much, organizer, for having me here for the second time. So this is our everyday clinical reality. We see those patients with BTK involvement every week, every day, and they are Rutherford 5, Rutherford 6. They have calcifications. They have bad and sad disease as defined by Ferraresi. And we do a procedure, then another redo procedure, and another redo procedure, and we kind of accept this fact. But the question is it the same old story? Can we improve the long-term, especially the long-term results of below-the-knee angioplasty? And we always place a lot of hope in new devices that are coming to the market every half a year, every year. And this is one example when we were hoping that bioabsorbable stents would be used for below-the-knee arteries. The concept was sound. However, the device failed in the coronaries, and the decision of the company was to pull it from the market for PAD as well. Right now, there is a renewed interest in the same device. It's reborn as Esprit BTK bioresorbable system, and again, a trial probably has started recruiting new patients. So we'll see how that goes. We don't have definitive data, and just to remind you, they use it only for short lesions, so not real-world critical ischemia patients. So maybe instead of borrowing stents from the coronaries, we would like to use a self-expandable stent dedicated for BTK. And again, the Saval RCT trial was stopped because the results were worse than POBA. Atherectomy for decades seems like a good choice, but if you look into the data, people are using atherectomy mainly for short eccentric lesions in the SFA and the popliteal, and I doubt whether the atherectomy will be useful for long below-the-knee lesions that are often 20 and 30 centimeters in diameter. There have been many trials using drug-eluting balloons. Just to remind you, the first one, the Impact Deep, which failed and was stopped because there was a higher amputation rate in the group treated with DB. But this was the first generation of drug-eluting balloons. Dr. Illistro from Italy is doing a lot of trials regarding the drug-eluting balloons below the knee, and he was enthusiastic initially in 2020, as you see, saying that there was a strikingly low number of late lumen loss. However, in 2022, he published another study stating that overall survival was similar in both patients treated with DCB and POBA in both groups. One of the problems we have in below-the-knee arteries are dissections. We don't know how to treat them. We don't know how to assess them. There's two devices on the market. The first one is a balloon with spikes, a seronator. This is supposed to distribute the pressure more evenly, avoiding dissections. And another very similar system is a spur stent system, which is a temporary stent that you open in the tibial arteries, you penetrate the intima and the media, and then you do angioplasty, allowing for a more controlled dissection angioplasty. In both cases, you can use a drug-eluting balloon to allow for better penetration of the drug into the vessel wall, actually to the media, where it should work. We know this device, it's used in iliacs and DSFA. I cannot show you any conclusive data, especially randomized clinical trial in real-world population. And just to remind you that any company introducing any product to the market is showing us mainly the efficacy and safety study. In this case, success was defined as less than 50% residual stenosis, and it doesn't necessarily translate into long-term success, which is amputation-free survival, because for clinicians, this is the ultimate and the only endpoint of any study with CLI. You can treat dissections with this novel short stent. It's called TAC. Probably you know this device. And again, I'm showing you this data with a highlighted, showing that probably they used it in not as challenging population as we see every day, because 93% of limb salvage at 3 years, that shows that the device probably was used in the initial studies for short and more simple lesions. So we are confused. I'm confused. Should we do atherectomy, DCB, TOBA, POBA, seronator? It's too many choices. And if you're confused, sometimes you have to take a step back and get a wider perspective. I think that we should learn anatomy of the foot vessels, especially because these are target artery paths or angiosomes or woundosomes, whenever you call them. There's a beautiful paper from Marco Manzi, Mariano Palena, available for radiographics. There are anatomical variations, and sometimes it doesn't make sense to open an artery that has no ending distal outflow. So we should learn this anatomy as just cardiologists are using for coronary arteries. And we often neglect the fact that there is a recoil after angioplasty. This is a paper published 10 years ago, and I think this concept is still not utilized properly, because what they left the sheath in the groin for 15 minutes, and they came back after 15 minutes doing angioplasty, and they found that in almost 100% of patients there is a significant recoil. This is illustration from this paper, and you see peroneal artery. And after 15 minutes, there is a significant recoil. And they came back with a bigger balloon and probably longer inflation, achieving a desired effect. So I think that we underutilize long inflation time. It has been documented in many trials. It should be at least 3 minutes for below-the-knee vessels. And the Japanese authors even suggest longer times of 8 or longer time of prolonged inflation. And do we get the vessel sizing right? And this will be addressed by 2 presentations, I think. This hasn't been planned, but I think that IVUS will help us appropriately size below-the-knee vessels. This is a patient I saw on Monday at the outpatient clinic, and this is a CTA. And if you do angiography, probably this is the size of the balloon you are going to use. And probably it doesn't matter if it's paclitaxel, sirolimus, seronator. This balloon is too small. You should use a bigger balloon. This is my practice over the years, that I always tend to use bigger balloons, and I'm always surprised by some of the operators deciding to use, 2.5 millimeter balloons in the proximal part of the anterior tibial. This is clearly too small, because the angiography is misleading. And you see more and more patients about IVUS. I'm not using IVUS myself. I don't have access yet, but I'm following the literature, and the results are consistent. We underestimate the diameter of the below-the-knee vessels by one-third, 30%, or 1 millimeter. It's significant for below-the-knee vessels. So I think that we got so much better in planning. We have access, we're using closing devices, we have better tools, better balloons, better guide wires, we are better at post-op medicating these patients. But the areas that we probably should improve and we should focus is proper angioplasty, because no matter what you use, the third generation drug-eluting balloon, if you take a balloon that is too small and you use it for a short period of time, it's not going to work. So prolonged angioplasty with probably bigger balloons that we are using right now. And we should know limitations of BTK procedures. And this is concept developed in Italy, SAD disease, small artery disease. There is no outflow in the foot. So if you use angioplasty, atherectomy, IVL, the result will be the same. So you should switch gears and you should go to use another method, which is PDVA, which I think the next speaker will be covering in detail. So take-home messages: we should learn foot anatomy, learn the true diameter of BTK vessels, and I think IVUS will help. We should do proper angioplasty, long inflation times, repeated if needed. It shouldn't be a 30 seconds procedure. And if we assess the new devices that we see on the market that are offered to us, we should look for quality data, which is long follow-up, 2-3 years minimum, not 6 months, CLI patients only, and we should look for clinically valid endpoints. And late lumen loss, binary stenosis are probably an information that device is working, but what we should be looking for as operators, doctors, is amputation-free survival, wound healing, because this is the only valid clinical endpoint. Thank you very much.
Thank you very much. So I have a question about PTA in the crurals. If you have the case with a diabetic patient, you're using always drug-eluting balloon or perfect plain balloon dilatation, long periods?
I tend to prefer POBA for longer periods of time. I don't think we have appropriate data. We have data for the SFA and popliteal impact SFA, 5-year follow-up. I think this is reasonable. I haven't seen equivalent data for below-the-knee arteries, so that's why I try to stick to POBA, appropriately performed, long inflation times, bigger balloons if needed.
All right, thank you very much. Questions, please, comments, who wants to discuss about it? Please, of course.
Thank you very much, very insightful. And what are your thoughts on sirolimus below the knee? The same Dr. Listro is now performing a trial, and Dr. Cho from Singapore is also showing good results. I think they have 2 years, and they have a better results to prevent amputation.
Well, the studies that are published involve relatively small groups of patients, like in dozens, maybe 100, and I think this is too small. And if you think back, thinking about the first trial impact SFA that failed, have they used appropriately sized balloons? That's the first question, because I think we are gathering data regarding the IVUS below the knee. And I think only then your therapy can be successful if you deliver the drug to the vessel wall. And maybe those seronator devices or the Spertzen system will help us to deliver the drug where it should be because of the calcification. So you use a drug-eluting balloon, I don't know if it's really working. So I'm only convinced when you come to the SFA territory, I always look for 5-year data, and there are not too many products that have 5-year data. Mostly it's 2-3 years, which is, I think, too long. It's too short, it's not too long.
Any questions more? Thank you very much.
Thank you.
Very nice presentation. So we have a next presentation from UK, Dr. Syed, about endovascular techniques in below the knee, yes? Yes.
Percutaneous deep venous artery.
Yes.
Thank you very much, Mr. Chairman. It's a great pleasure to be here. And I think my talk follows in very nicely from the previous talk. So these are my disclosures. So This talk will be addressing this group that my previous speaker in his elegant talk explained, where we have no option, they have no option. And those are the ones who either have a desert foot like these ones, or as we've heard already before, heavily calcified pedal vessels, which can extend sometimes the extent of calcification as well to the digital vessels. And we know that even if you do spend 5 hours opening these foot vessels, they will run for a few minutes and then they will go down. And based on this, it sort of emerged the concept of recruiting the deep venous system of the leg and the foot to deliver the oxygenated arterial flow to the area of the tissue loss. And the idea behind it is that you try to change the anatomy of the perfusion in a desert foot into this picture where you have an arterialized foot venous arch with reversal of the flow into the tributaries as well. However, if I stress on one important thing, this is one of the important factors that we have to keep in mind. It's the patient selection, and it has different views. The first one is the anatomical criteria. So each patient has to have a good inflow vessel, like here the posterior tibial. It doesn't have to be perfect, but you can optimize it and you can use it as an inflow to your circuit. But also you have to have some collateral flow to the foot, because this fistula doesn't work instantaneously. It does require some time, like the arteriovenous fistula for dialysis. And during this time, we need to ensure there's some flow to the foot to keep it alive. Also, we have to make sure that these patients have patent deep venous system. Otherwise, there will be no outflow for the arterialized vein. So patients with deep venous thrombosis are unfortunately excluded. And more importantly, it's the amount of the tissue loss in the foot. So forefoot tissue loss can be treated, but also it's important to realize that if the foot tissue loss or damage is too extensive, it's probably it will not sort of remain alive until you actually get the arterialization of the deep veins. So I'll just briefly mention the technique for those who are not very familiar with it. So this is a quick video, and this talks about the use of the lymph flow system, which is the only CE marked system so far. We start with ultrasound-guided access through usually the lateral plantar vein. Also, once we're happy with the access and the quality of the vein, we obtain an antegrade common femoral access, as we do with any antegrade angioplasty. And we can cannulate our inflow vessel and introduce both venous and arterial catheters. You deploy the venous catheter, which is like a basket, so it distends the vein, make it an easy target to aim for. And with a similar to re-entry device on the arterial aspect, you try to target this basket and introduce an 014 wire. And then you use this basket in the venous side to capture and snare the wire. By doing that, you will have a through-and-through wire, so coming from the common femoral artery and coming out from the lateral plantar vein. You start with the gentle dilatation of the fistula, but then we have the valves in the deep veins that we have to address. And for that, you use forward-pushing valvulotome, similar to the surgical valvulotome that we use, but it's over the wire and it's a forward-pushing, which effectively lies all the veins in the deep venous system. Once you've done that, you have then to start stenting the venous side. And this is, number one, to keep the vein open, obviously, and deal with any residual valves, but also to deal with tributaries. And you stent sort of single sort of diameter stent until the point of the crossing. Then you come to the purpose-built tapered stent, which goes from the venous side to the arterial side, just to keep the fistula open. And by doing that, you now establish flow from the inflow artery through the stent into the outflow, most of the cases, lateral plantar vein. So these are, for example, this is an example of one of those patients with extensively calcified foot vessels and almost like a desert foot. And if we give them the time, you can wait until you get reversal of the flow into the digital venous veins, which are now arterialized, and this can heal any tissue loss you have. It's not sort of that simple to a great extent, because it's not just the procedure. When you're done with it, you're done. The post-operative care is a very important aspect of the treatment, because those patients tend to get what we call post-operative storm, because obviously when you arterialize the vein, they can develop ischemic pain because of the steel phenomenon. Also, because of the high arterialized flow into the vein, they get venous hypertension and foot swelling. And we really struggled in our first couple of cases or patients in this series because post-operative pain in the first 2 or 3 days was quite significant. And that's why now routinely every patient, before they leave the operating table, they have a sciatic nerve block. And this nerve block stays in for, can stay in for even up to 7 days. And it's really important because it takes away the rest pain. It allows them to keep the feet up and get rid of the swelling. And you will be amazed because after some time, when the fistula matures, when you take these patients, for example, for a transmetatarsal amputation, you can see a pulsatile flow in the cutaneous veins. And also, if you look at the arterialized deep veins, this is an arterialized deep vein in a foot, which previously was considered no option, and we were talking about a below-knee amputation. What we learned as well is that those patients, we try not to close them primarily. It doesn't matter how it looks nice to you. You can try to use vac dressing or any dermal substitute and later on skin graft. As I mentioned earlier, it's not a one-stop shop. These patients have to have a very close follow-up because what you try to do is to try to divert the flow towards the foot. And you can see here because the flow will tend to go back into the venous system. And you can try to do what we call focalization or coil embolization to push the flow and cause what we call a valve fatigue to redirect the flow into the veins towards the toes rather than back again into the upper part of the leg. And with time, this happens. So you can see after the procedure, you can see the arterialized flow into lateral plantar vein, but you can't really see any arterialized digital veins. But if you give it time, and usually this is 2 to 4 weeks, what happens is that you can see now arterialized digital veins, which can perfuse the forefoot. So all well and good. So what is the evidence behind that? I have to say, with time, we're getting more and more evidence to support this technique. So the biggest study is the pivotal PROMISE-2 US study, which included 20 centers, 105 patients. And all 6 they are proper CLTI patients. 20% were on dialysis. All of them were rather 4, 5, or 6. The 6 months data showed that the limb salvage rate is 76% with amputation-free survival of 66% at 6 months. There was quite an obvious difference between those on dialysis and those not on dialysis in terms of the 6 months amputation-free survival or the overall survival. So if you had dialysis, you're far more likely that you will either lose the leg or you will be dead in 6 months in this group of patients. The latest evidence comes from the UK, where we published the PROMISE UK study, and this goes with a follow-up to 1 year. Again, CLTI patient, rather 4 to 5 or 6, included 6 UK centers. Between us, we recruited 28 patients. All of them had tissue loss with various degrees. And as you would expect, again, almost 20% were on dialysis, and more than 90% of them had a previous attempt at the same leg of revascularization. The technical success rate was 96%, so only 1 patient that the procedure was not achievable, with 85% of those patients were able to be discharged home from the hospital. And when we look at the 1 year amputation-free survival, it was 67% at 1 year. But more impressively, the limb salvage was 81% at 1 year. So 4 out of the 5 patients that 1 year ago we thought that they should go for a below-knee amputation still maintained or kept the leg at 1 year. 75% of those patients had complete healing of their wounds by the end of the year. I would have loved to stay here and say this is a sort of a great operation that each one of us can do, but this is far from being just a one-man show. This really is a program of limb salvage, and the operation is a one-time time point in their journey. So it requires really a proper advanced limb salvage team, including podiatrists, including infectious diseases, diabetologists, theater nursing, radiologists, surgeons, and all of that. So this is what I would advise to start with, then learn the technique. It's setting up the advanced limb salvage team before you learn it. So in conclusion, Mr. Chairman, ladies and gentlemen, I think we are gradually getting growing evidence to support that PDVA could be considered in patients that my colleague mentioned earlier are not suitable or are not deemed appropriate for conventional revascularization procedures. It's important to pay attention to the patient selection. There is a learning curve, but it's not a steep one. Those patients need to have a very close follow-up within a multidisciplinary team and have a low threshold to intervention if any problem is identified. And I thank you for your attention.
Thank you for a very nice presentation. For this patient group, this is no option. Any questions from audience? Please.
The microphone is just very close. Please turn around. Yes.
If you have some infections of the implanted graft because you have infection in the foot and you implant the prosthetic.
Yeah, so we've experienced zero of this. So we never had any infection in a stent implanted in an artery. It's similar when you have like tissue loss and you put a stent in the SFA, for example. So we've never taken any patient back for stent graft infection, if that's what was your question. Luckily.
We see it in our clinic too. It's no infection.
Yes, yes.
It's, and the second question is, have you tried to do it complete open? Because if you doesn't have this valvular term, if you have no equipment, no stent graft, but you can, for example, make in situ bypass vein graft to the foot vein.
Yeah.
And what do you mean if, how can we valvular term to distal part of the vein?
Yes.
Well, in my experience, sometimes it's off-label, but I make cutting balloon.
Right. Yeah. So as I mentioned earlier, so the data that we have on the long-term data is for this device, which is CA approved. I'm aware, and we've done some sort of off-the-shelf procedures, but we don't really have long-term data. In terms of the open deep venous arterialization, this has been being done from the 1977. The first paper was 1977 with 10 patients. And I think those are the ones that probably you would worry about, because having foot infection and you put a prosthetic graft like under the skin, those are the ones that tend to get infected. I personally haven't done that with the prosthetic graft to the deep system, but the data is already there, and it's not necessarily that strong or promising data, and that's why this was one of the reasons the attention shifted towards the endovascular or percutaneous arterialization of the deep veins.
Thank you.
Thank you. I have one question. Sure. What stent graft do you use, and what sizes of diameter it is?
Say again, sorry?
What stent graft do you use?
So the system comes with a stent graft. The stent itself, the straight section, is 5.5, and it comes in different lengths. The tapered graft is 5.5 to 3.5. So the 5.5 goes into the vein and then tapers into the artery.
Okay, thank you.
Thank you very much.
Thank you.
Thank you. So the next presentation will be Professor Torzella and everything about IVUS.
Thank you so much for the kind introduction. I have to say that I'm not the author of this presentation. The author was in Frankfurt, and the flight to Vilnius was cancelled, and he asked me to show his slides, and I tried to do my best. These are his disclosures. And first of all, I would like to speak about why we should consider IVUS. And we start with the clinical case. You see, this is an everyday case with claudication on the basis of femoropopliteal disease. And these are the costs at his institution for the different therapy options for bare metal stent, for DCB, for drug-eluting stent. And if you make also additional measures like atherectomy, IVUS, or cover stent, of course, the price is higher than you can imagine there.
So in this case, the operator decided to recanalize the lesion and also to put a bare metal stent. That was an easy choice, but 70 days later, the patient came back with the claudication, and the angiography showed wrist stenosis with thrombotic apposition at the level of the SFA. So the lady had to be treated again with an atherectomy, which cost 2,100 euro, DCB, and he was not very satisfied with the results, so he covered the lesion and the thrombi with the self-expanding cover stent, which makes a cost of 5,300 euro. So this is only the material cost. If we consider now the cost of the entire treatment of the patient based on an evaluation made in Europe by Professor Saratzis and published also in the European Journal, you can realize that the cost of a TLR are extremely high. As you see, by endovascular means by 12,900. If the patient has to be operated, the cost will be 23,000 euro in median. So it's imperative to avoid TLR. And which are the causes for target lesion vascularization in such patients? The calcium, the dissection, but also subintimal crossing, stenosis, which is underestimated, and sometimes also sizing issues. And there is a prospective randomized study performed by Dr. Ko and published in the European Heart Journal, showing that IVUS can improve the results. As you can see here, the IVUS, the treatment performed by IVUS with IVUS guidance showed a better primary endpoint. There was a primary patency, freedom from CDTLR, and sustained clinical improvement, and so on and so on. And then he looked also on the difference. And you see the difference was not based on the use of DCBs or something very difficult. The difference was based on other things like maximal post-balloon pressure or adjuvant post-dilatation, and so on and so on. So technical things which were performed during the primary operation. Now, how he does the procedure? Well, that's easy. You advance the IVUS catheter of a low-profile balloon, and then by pull back, you see the images. Now, what can we see with the IVUS? You see, you can measure the amount of the stenosis. For this, it's extremely important that you have a vessel reference, which is not at the level of the lesion itself, but it's above or below the lesion. This is the vessel size you should consider if you want to choose the right balloon, as pointed out also before by Dr. Lena. And also you can make your measurement, if you like, of the lumen, of the plaque burden, and so on. The second thing you can appreciate during IVUS is the type of plaque. In this case, we have an ecogenic or fibrotic plaque, and you see it's white. It's white like the adventitia. If you have some dark spots or dark mass within the plaque, well, this is a sign of echolucent soft plaque, a sign of instability, which probably in the leg is not so that important, but if it's at the level of the coronary, at the level of the carotid, or at the level of the renal artery, can have an impact on, in sense of distal embolization. You can also see the plaque geometry of the lesion. And it's different if you have a concentric or eccentric plaque. It's different because if you want to make an atherectomy and you have an eccentric plaque, well, a directional atherectomy would be much better. But if you have a concentric plaque, a rotational atherectomy would be indicated. The easiest lesion to identify by IVUS is the calcified plaque. And you see here, you see the arrows showing a dense white formation of calcium, and behind you see a shadowing, which is black. This indicates the calcium, and the calcium can be superficial and deep. And again, it's different if you have a superficial calcium formation or a deep. Deep, we don't care really about this, but if it's superficial, there is a risk that your stent or your device will not expand. That's extremely important. Another thing which can be detected by IVUS is the position of the wire, especially in very long lesions. You don't know if you are in the lumen or you are subintimal. And this has impact also on your treatment options. If you are subintimal, it doesn't make any sense to make atherectomy, probably also DCBs, use DCBs. So it's important to know where you are with the wire, and with the IVUS you can see this. And last but not least, the finding after stent implantation. You can have two different pathologic situations. One is the malapposition, the other one is underexpansion. Which is worst, the malapposition or the underexpansion? Well, worst is obviously the underexpansion, because there is a risk of wrist stenosis and reocclusion. Malapposition is not beautiful to see, but if you consider that in many cases after severe stenosis you have a post-stenotic dilation, where sometimes the stent wouldn't reach the vessel wall. That's not very important in sense of dynamic. It's not important. And also, it's important to see what happens at the end of the stent, because very, very often, at the end of the stent, you can have a dissection or a plaque rupture, which is the origin for a wrist stenosis or reocclusion. So it can be useful. Now you can see these pictures. You see the IVUS picture and the corresponding arteriography of the left iliac artery and femoral bifurcation. And you see at level of A, at the angiography, we don't see any stenosis. On IVUS, we see a calcification, but we see also a white lumen, so we don't need to treat this at all. At level B, we see an old plaque rupture, which doesn't have any effect on the hemodynamic. On C, you see again a calcified plaque which is more than 180 degrees, with the lumen, vessel lumen of more than 50%, where you can treat this patient, but only if he has really symptoms. You can see also bifurcation with the IVUS. You see at the level D, the bifurcation of the common iliac artery in the hypogastric and the external. And also at level H, you see the bifurcation of the common femoral artery in the profunda with the small calcification and in the superficial artery. And you can see also the normal vessel at the level of the SFA, the I, at the level of the common femoral artery, F, and also at the level of the external iliac artery, which is E. In conclusion, I would say, of course, we make our therapy always angiography based, but IVUS can be useful in complex lesions, assessing the plaque and the lesion morphology, guiding and controlling your treatment option, and improving in this way the acute and long-term results. So he says at the end, the more you give, the more you gain. And IVUS is an investment that will yield clinical and economic returns. The more complex the case, the more I lean towards IVUS use. Thank you for your attention.
Thank you. Any questions from audience?
Okay. Thank you.
Yes, I have a question.
Oh, yes, please.
I'm very sorry, microphone was turned off. If you have a lot of money, you do it in every case, or you select the IVUS?
IVUS is expensive.
That's why I'm asking.
Yes.
Yes.
I would use it only specific case, or if I want to learn something. In the past, I treated my patients with below-the-knee lesions with 1 millimeter or maximum 2 millimeter balloon catheter. Now, after I use the IVUS, at least 2.5 to 4 millimeters, depending on the level of the lesion. So I learned a lot with the IVUS, also to make my strategy better than before.
Okay, thank you very much. Thank you.
Welcome.
So we need to push on. Thank you, Professor Torsella. And the next presentation will be Dr. Brodnus. And IVUS cost effectiveness, yes, I understand about it.
Hello, my name is Drobnis. I'm working in Klinikum Hochsauerland in Germany with Michael Lichtenberg, and I will present the talk about the cost and utility analysis of IVUS in PID patients. I have no disclosures, and this analysis was published in journal Vasa last year. Despite the growing interest in IVUS, the cost utility is unclear. And DRG Germany may not sufficiently cover the cost of IVUS. As we heard, the IVUS has higher efficiency and accuracy in device deployment. There were economic evaluations have been used to quantify the value of IVUS, but there is a paucity of such studies. And this analysis, the aim of this analysis is to investigate the cost effectiveness of IVUS guided PTA over angiography guided PTA in PID patients, very important in Germany. To aid decision-making by a physician, hospital administrations, and policymakers. There were a model developed for cost effectiveness in line with recommendations of Institut für Qualität und Wirtschaftlichkeit im Gesundheitswesen und International Society ISPOR. You show the model is there are patients, PID patients with FEMPOP lesions, because this analysis were concentrated on FEMPOP lesions. IOS-guided PTA versus angiography-guided PTA and standard outcomes, the TLR or target lesion revascularization, amputation, mortality, quality of life, and costs. I repeat, this was the German payer perspective. The time horizon was 1 year and lifetime, and there were discount rate. What does it mean? That in different regions of Germany, there are different costs of IOS. Discount rate was 3%. And model structure was 1 year decision tree, followed by lifetime Markov model to analyze the long-term outcomes with a cycle of 1 year. Because the IQVG, Institut für Qualität und Wirtschaftlichkeit im Gesundheitswesen, have no clear willingness to pay threshold, there were threshold willingness to pay adopted to this analysis is 50,000 euro divided by quality adjusted life year. And you show the schematic diagram. It's FEMPOP lesions, 2 arms, IVOS-guided and angiography-guided PTA. The outcomes, 1 year decision tree, and the lifetime Markov model. The inputs for this model were derived from the literature and national sources. There are robust literature data for the clinical and utility parameters, and cost parameters were derived from German DRG system. Assume that the cost of IVOS will be once-off cost on top of the existing PTA costs. The primary outcome was incremental cost effectiveness ratio. You show the diagram where is the incremental cost divided by incremental quality of life. And the results of incremental cost effectiveness ratio were it was less than willingness to pay threshold. It was cost effective. If it was more, it wasn't cost effective. And you show results, and we can see that IVOS-guided PTA was shown to be cost effective over angiography-guided PTA in 1 year horizon. And dominant, it means the cost saving and having better outcomes in lifetime horizon. Why? Because the precision of device deployment and avoidance of TLR, target lesion revascularization at 1 year, and less amputation is because of the quality of index procedure and lifetime perspective. Utility, post-target lesion revascularization and probabilities of death and TLR were the main drivers for the showed incremental cost effectiveness ratio in the 1 year horizon. And costs and probabilities of target lesion revascularization and amputation were the main drivers for the observed incremental cost effectiveness ratio in the lifetime horizon. And the IVUS-guided PTA was found to be 50% cost-effective in the probabilistic sensitivity analysis using 1 year horizon, and probability of IVUS to be cost-effective increased to 86% in the lifetime horizon. This analysis has its known limitations. Because the parameters of this model are from the literature sources, despite the literature sources are sufficiently robust. The results cannot be extrapolated to the lesions of a different size. There were just FEMPOP lesions. And inherent uncertainty exists due to the need for data assumptions and extrapolations. And the conclusions, adjunctive IVUS during the PTA was cost-effective at 1 year and cost-saving at long term. Main reason why my opinion was of the quality of index procedure, of better visualization of plaque morphology, and the IVUS-guided PTA has less TLRs, less stent occlusions, and in the lifetime, less amputations is the logical consequence. Thank you very much.
Thank you very much for your presentation. So we need to push on because we have a couple of presentations still to listen. And the next will be Professor Torsello. Please, again, the stage is yours.
Well, I was asked to speak about the best CLI and if best CLI would change my practice, at least. Thank you for the question, Thomas, and it's a big privilege for me to show the results of this study, which together with the Basel II and Basel III filled a bit the gap between the prospective randomized study for CLI and the numerous studies done for coronary disease or for carotid. And you see the list here, and the list is for sure not really complete. At the beginning, I would like to show two different aspects of the BEST CLI trial. The first one is the primary outcome, which was male-free survival. Doesn't have anything to do with our sex, but with the major adverse limb event-free survival, which includes death, of course, a major amputation, but also major reintervention at the index leg, including not only thrombectomy, new bypass or graft revision, but also the conversion from endovascular to open surgery, which is extremely important in this context. Everything was adjudicated by an independent clinical events committee. The second point is that this study included two different cohorts, depending if the great saphenous vein was suitable for bypass. This was included in the cohort 1 or not. This is the cohort 2. And you see immediately also the superiority of the surgical therapy in these patients in both cohorts. But in the cohort 1, this was statistically significant. In the cohort 2, was not statistically different. Another thing which is a bit surprising is the result of endo in the cohort 1 and cohort 2, and we don't have any explanation. I understand if you use vein or prosthetic graft, you have a difference, but not if you use the endo. Which were the procedure performed? They performed, in the most cases, a bypass graft fem-pop or femorodistal, and in 85% with only one piece of vein. In case of endovascular, the most were at the level of the SFA and the popliteal, but a huge number also at the level of PTK. And another argument against the surgery was that these patients, even if they had a lesion of the SFA or popliteal, were treated mostly by POBA. Another point is the technical success. The technical success with the bypass graft was very, very high, but after endovascular procedure was only 85%. And this explains also the curves in this Kaplan-Meier evaluation of the male-free survival. You see the difference was only at the beginning based on the technical success, which was superior after surgery compared to endovascular. But the lines are parallel during the following months and years. This trial has very important strengths. It's an international, well-designed, effectiveness prospective randomized study with a pragmatic design, and this is very important for future trials. And it's first of the sides in CLTI. You see here more than 2,500 patients were assessed, and 1,847 patients were randomized in 150 centers, mostly in North America, but also a couple in Finland, in Italy, and in New Zealand. And you see that most patients were included in the cohort 1. But there are some points to discuss. The first is the high technical failure after and reintervention rate after endo, which is probably due to the fact that the patients were treated some years ago, between 2014 and 2019. And during this period, for example, the retrograde access for crossing was used, but only in a few centers. Also, the lack of new vessel prep techniques has an important role in for the technical failure which was observed during the first, and the reason for the conversion to open surgery. But the question we have is, to which population do the findings apply? And this is the basis for answering your question, Thomas. The patients with the CLTI are heterogeneous in their systemic risk. They have different severity of limb threat and also anatomic complexity. And if you have a look at the exclusion criteria, the patient must they should have a good surgical risk. It means that patients were excluded if they had an excessive risk associated with the open vascular surgery, according to the American Heart Association, American College of Cardiology. So very interesting is this slide, which I have from Popplewell. Popplewell is one consultant in the center where the PI of the Basel II works. So he was very interested to include patients. But you can see what happens with these patients. You see during this period between 2014 and 2018, at their department, they saw more than 400 patients. But 155 were treated without any revascularization. And only 315 with revascularization, but suprainguinal in 78 patients. So at the end, they could randomize in the Basel II trial only 17 patients. That shows how difficult it is to make a prospective randomized study in this type of disease. Which are the obstacles for randomization? Well, first of all, the patient would for sure prefer an endovascular attempt first, but it's also for the center is easier to obtain imaging and to obtain access to an operative theater if the patient has to be treated with the endovascular, and everybody here also in the room knows about the pressure we have with the beds and with the patients waiting for the treatment, especially if they have rest pain. And obviously the patient prefer a minimally invasive intervention under local anesthesia and not a long bypass. And they conclude that prospective randomized study can only study subgroup of patients, well defined according to inclusion and exclusion criteria, and these patients must be suitable for both, for the operative therapy or for endo. So that the patient excluded from this trial are normally more female, have more diabetes, have more comorbidities, and more severe tissue loss. And this explains the higher morbidity and mortality of these patients which are not included in the trial. In summary, in BCLI, we have a superiority of bypass compared to the endovascular therapy for this disease. However, the benefit of surgery was driven by endo patients converted to bypass. And the best CLI evaluated a limited subgroup of patients with critical limb ischemia, while the real world patients, the patients we see every day, are usually older and have more comorbidities. So in order to answer your question, how best CLI changed my practice? Not very much, actually, because my therapy focuses on the patient and is tailored to the single patient, to the individual patient, according to the lesion, according to the defect, according to the comorbidities of this patient. Thank you for your attention.
Thank you very much. So, thank you, Professor. We have a very soon gala dinner, and you are coming, yes? Okay. And if somebody wants to ask questions from you personally, you agree to answer, of course?
Well, I will be at dinner, so if you have questions...
Yes, yes. So, some questions to the professor, or maybe later. Thank you very much. So, we'll have one more presentation from Riga, from Latvia. Do you want to say something?
No. This is my colleague, Dr. Aina Krotowska. Please, stage is yours.
Dear colleagues, as I last obstacle between us and the gala dinner. I'll make it quick. So I would like to present one case of carotid artery stenting, which was technically really nice, but the clinical result was like cake with the cherry on top. So just a regular case, 75-year-old woman. She had a carotid artery endarterectomy 1 year ago. She also has a left internal carotid artery stenosis, like 60%. And for now, she's asymptomatic. On a control CT angio, restenosis of right internal carotid artery was detected with the stenosis rate close to 19% in the area of endarterectomy. She doesn't have any additional risk factors. She's not diabetic, she's not hypertensive, she's not smoking, she doesn't have any coagulation disorders, only slight dyslipidemia. So always before we go for carotid artery stenting, we do at least non-enhanced CT of the brain to rule out prior ischemias. And as you see in this non-enhanced CT, there is no lesions in the brain. And this is her DSA angios. As you see on the left side, this is a prior any intervention. So this is a DSA with a really tight stenosis. And just in a regular technique, even if it's a status post endarterectomy, we anyway use the filter devices. And in this case, it was also done the same way. We did the pre-dilation with a 3 millimeters diameter balloon catheter. And in this case, we placed the stent, road saver 7x30. We did the post-dilation with a pretty small, I would say, balloon. It's 4.5x20, keeping in mind that the patient had really tight stenosis, and that's not a simple stenosis. This is a status post-endarterectomy, and it's a restenosis in the operation area. That's why over-dilatation in these cases is known, that it may end up with a bad result. And it did so. The patient, the procedure was ended up. She was neurologically absolutely normal. She was transferred to her neurology department, and she was lying in the bed, and 7 hours after the procedure, she was already walking. After the procedure, she developed slight left-sided hemiparesis. She was still talking to us normally, so no signs of aphasia. And of course, due to these neurological symptoms, we did emergency non-enhanced CT, and a huge intracerebral hematoma was revealed. During the procedure, we used only 5,000 units of heparin intraarterially, and prior to the carotid artery stenting procedure, she started dual antiaggregation therapy 1 week before. So what happened to this patient? Of course, nevertheless, her symptoms were not so severe. She didn't have very deep hemiparesis, but still, neurological deficit was obvious. And you see on this slide, her last CT before discharge. She was discharged with gradual resolvement of the symptoms 2 weeks after the angioplasty with ECOG status 1. And, of course, a slight neurological deficit due to this large amount of intracerebral hematoma and leukoencephalopathy left on site. Reperfusion intracerebral hematomas are rare. The reported incidence is like 0.7% of all carotid artery stentings, and the main risk factors, as we know, pre-procedural hypertension or peri-procedural hypertension. That's why all of our patients after carotid stenting are under close monitoring of the arterial pressure. And also as a risk factor, it's a subocclusion and PTA of a subocclusion, which was also this case. And even due to precautions and post-dilation with a smaller diameter balloon than regularly, still in this case, the patient developed intracerebral hematoma. And of course, in this patient, we immediately withdraw dual anti-aggregation therapy, and that's always a question. You just put it the stent, you want it to be patent, and you have to withdraw all anti-aggregants. This is a nerve tickling situation, but due to a large amount of intracerebral hemorrhage, you cannot continue. That's why we actually did duplex ultrasound surveillance for her stent every day in the 5 days after this event. And this case, of course, raises a question: how to behave in the patients with either very tight restenosis after endarterectomy or just severe stenosis of a native carotid artery. Should we do only, let's say, two-step procedure with a small balloon dilatation in the first session and then going for real angioplasty afterwards to reduce the risk for reperfusion intracerebral hemorrhages? Or maybe there is another approach. So that's the cherry on top for you, and maybe either Preet allows me to discuss it now or at the gala dinner table.
Of course, we'll do the very short, thank you very much, very short discussion. Professor Torsello, do you have some ideas to comment?
Thank you. Yes, I have a. At the 10 years or 15 years ago, some studies with the transcranial Doppler were done. And the colleagues saw that the most neurological deficit come not through carotid stenting or pre or post dilation, but by attempting to engage the common carotid artery or the brachiocephalic artery. So before I make such an intervention, I always make a CT scan watching at the arch. I don't know if it's the reason for that, but in the last slide you show, we have some changes in the posterior vessels. So I'm not a radiologist, so, but I suppose that was probably a shower before you engage the common carotid artery.
Yeah, we actually do CT angio in every patient undergoing carotid stenting to be, of course, technically prepared and also to understand what's going on in the other vascular territories of the brain. And actually, well, I didn't put that in the presentation because it's 10 minutes, but we also did MR, of course. And in MR, there were no acute lesions, no DVI, hyperintense lesions, nowhere else, only hematoma.
So it's mean that we don't know the exact reason why it happened. So thank you very much, everybody who is still here, and the first day of the Vilnius Vascular Symposium is ending, but not quite. Gala is waiting, and we'll have the second day tomorrow. Have a nice evening.